Bismillah ar-Rahman ar-Rahim. I would like to welcome you all today in our 41st annual Congress for the Faculty of Medicine at Ain Shams University. Actually, it's not only a Congress, it's a sort of medical week, and the idea emerged some 4 years ago when we decided to join forces and to unite all departments, whether clinical or academic departments that used to have their annual Congress alone and single-handed. The visibility within the faculty, within the academia was not enough. That's what I believe by that time. So the decision was to try to get everybody together on board. A sort of multidisciplinary, interdisciplinary medical week, uniting all departments together to see each other, to share ideas, thoughts and insight with each other, not only within Ain Shams Medical College, but with their peers in Egypt, all sister faculties of medicine in Egypt, in the region and globally. And that's why we are very keen to host our friends and colleagues from around the globe, from the west and east, from the north and south, to share with us their thoughts and ideas and experience, and to end this week by MOUs, by partnering, by any sort of agreements for future collaboration, including training for nursing staff, for doctors, for young doctors, for even attending doctors, for paramedics, for research above all, and for joint international publication. One of the good things that we did over during the past few years also is to raise a dedicated medical research unit or department called MASRI, which is concerned with basic research, translational research and clinical research, and I believe it's a very good platform for our colleagues in Ain Shams University and their colleagues and peers from different disciplines to work together and to showcase all their work and experience in a sort of joint publication to the whole world. Coming to numbers, I believe that this 41st annual medical week in the premises of Ain Shams Faculty of Medicine that will start on the 21st and goes until the 27th. I hope that I can see you, at least or some of you physically, by the end of this week, participating 10 academic and 20 clinical departments all together, with invited 25 guest speakers and 7 working days and up to 126 total working hours. And this has been accredited by the European Accreditation Council for Continuous Medical Education. I cannot end my word without touching on what we all are witnessing in the world over the past, I would say, 1 year nearly now, since December 2019, when the COVID-19 pandemic hit the whole world very hard, I would say, without any exception. And I think this was challenging to all of us. One of the challenges that we are meeting today, and that we online, and we are doing it more or less virtually rather than physically as we used to do. But I think within the challenges that we all met over the past year, there have been some opportunities. One of them is the marked advancement, and thanks to the IT and technology, that we are more and more on webinars, daily and hourly webinars, virtual meeting, exchanging expertise. It didn't stop us in the academia, whether when it comes to e-learning or hybrid learning or any sort of acquiring skills. Obviously, we need physical existence, and we need physical meeting face-to-face for certain skills and for certain experience to be shared and to be exchanged. I'm sure that it will not be for long, and we will soon have more than one vaccine in the globe and an accurate treatment for the COVID-19. And I wish you all the best, and please stay safe. Thank you very much.
my honor to announce the 41st Annual International Ain Shams Medical Congress. It's Ain Shams Medical Week named towards the access to innovation. We have participating departments, 10 academic and 20 clinical, esteemed 25 guest speakers over 7 working days. We have also 126 total working hours. On the behalf of the Faculty of Medicine at Ain Shams University, I hope you first best of health in the current COVID pandemic, which despite its negative effects has empowered us to exert more efforts to reach and collaborate with many participants all over the world through webinars, and we are offering free registration to include the maximum number of junior staff all over the world. I'm looking forward to hear feedback from all the participants at the closing ceremony. I would like also to know your conclusions and recommendations. I hope to meet you all next year at the premises of Ain Shams University after the end of this pandemic. Thanks for all of you.
It's a great pleasure to welcome you all in the 41st Annual International Ain Shams University Medical Congress. We prefer to call it Ain Shams Medical Week. I want also to welcome all our guests from abroad who are joining us thanks to the technology and the internet. I'm really grateful to the President of the University, Professor Mahmoud Al-Mitani, and the Dean of the Faculty of Medicine, Professor Ashraf Omar, for their continuous support and encouragement all through the preparations. I want also to thank my colleagues, heads of departments, all the staff, whether seniors and juniors, who put the effort to make the Congress and who prepared the sessions, which I hope to be really fruitful and rich sessions. Thank you to the sponsoring companies who supported the Congress. I have special thanks also to IRIS, the organizing company, Dr. Ashraf Badawi and his team for always being with us in all events. It was really a tough year. 2020 was not a usual year. It was very special. We had lockdowns. We had travel were banned. We had even the gatherings, even the family gatherings were not allowed, which made us all somehow isolated to some extent. So I want to express that I'm really glad that now we have the chance to meet again, even through the internet, but still we can communicate, we can share our experiences. We can introduce our researches, our results, everything that we did this last year. I really wish a fruitful session, a fruitful Congress as a whole, and that each session to have a meaning. Thank you, and wish you all the best.
It's my pleasure to welcome you to the 41st Annual Ain Shams University Medical Congress that will be held between the 21st and 27th of November. There are 10 academic departments and 20 clinical departments participating this year. Because of the COVID crisis, this year is not a face-to-face experience, it's rather a virtual, unique experience that we hope you're going to enjoy. This meeting has 51 CME European credit hours, and there are 126 working hours during these 7 days. And this has been accredited by the European Council for Continuous Medical Education. It's important to know that in this meeting there are 25 international guest speakers and we hope it's going to be a genuine international experience. I would like to thank the support of the administration, the president of the university, Professor Mahmoud Al-Mitaini, Professor Ashraf Omar, who's the Dean of the Faculty of Medicine, Ain Shams University, Professor Shahira Samir, who is the Vice Dean of Faculty of Medicine, Ain Shams University, for supporting this meeting. As well, I would like to thank all the staff members, coordinators from different departments, and as well Professor Ashraf Badawi and IBIS for organizing this meeting and making this virtual meeting happen. I should not forget also the sponsors of those meetings, because without whom this meeting would not have been held. And I wish you all a very successful and pleasant meeting and pleasant experience with this first virtual Ain Shams University meeting. Thank you.
Doctors, we are ready.
مساء الخير.
دكتور احنا جاهزين. دكتور رانيا ممكن نبدأ؟
Professor Mona, please start. We are ready.
مساء الخير الأساتذة الكرام. اليوم نبدأ فعاليات المؤتمر 41 لقسم الأطفال جامعة عين شمس تحت رعاية أستاذ الدكتور محمود المتيني رئيس الجامعة، أستاذ الدكتور أشرف عمر عميد الكلية. وأحب أن أشكر القائمين على تنظيم المؤتمر، أستاذة الدكتورة شهيرة سمير، وأختي العزيزة أستاذة الدكتورة منال حمدي السيد، والشركة المنظمة آيرس ودكتور أشرف بدوي على المجهود الخارق في وقت الوباء كوفيد. طبعا الحاجات في وقت الكوفيد بتتعمل بطريقة أصعب جدا من الوقت العادي. مؤتمر جامعة عين شمس يتميز دائما بالعلم الغزير وكل ما هو مميز وجديد في كل أفرع الطب، وجامعة عين شمس هي منارة تعليمية فائقة الخبرة والتقدم. على الرغم ان المؤتمر فيرتشوال بيحرمنا ان احنا نشوف بعض وجها لوجه، ده يعني احنا كنا مبسوطين عشان هنشوف بعض، لكن يعطي فرصة أكبر لحضور أكثر من الأساتذة والأطباء وينشر العلم في جميع ربوع مصر. يسعدني وجودي من ضمن الأساتذة الأجلاء لقسم الأطفال أستاذ الدكتور مصطفى هدهد، أستاذ الدكتور طارق عبد الجواد، أستاذ الدكتور هشام عوض، أستاذ الدكتورة إيمان زكي، أستاذ الدكتورة حنان إبراهيم، أستاذ الدكتورة إيمان منير، أستاذ الدكتورة أمل فرماوي، أستاذ الدكتور وليد الجندي، ودكتورة داليا الغنيمي. أرحب بجميع الحضور والسادة الأساتذة، ونبدأ الكلمة. دكتور مصطفى جاء ولا لأ؟
هو الدكتور مصطفى عنده مشكلة في الإنترنت دلوقتي، فهو بس بيعتذر إن هو ما قدرش يجوين، بس هو بيتمنى لنا التوفيق في اليوم اللطيف إن شاء الله. طبعا دكتور مصطفى كان معانا من أول ما كنا بنجهز للمؤتمر من شهر مارس اللي فات.
هو كلمني وقال لي كده، بس قال لي هحاول اخش بالموبايل، يعني هو مش موجود معانا دلوقتي.
معلش هو ما دخلش، ما تمكنش ان هو يدخل. فطبعا هو يعني المؤتمر واحد من بكورة ابنائه، يعني المؤتمر السنه دي هو كان معانا من اوله من مارس اللي فات، فربنا يجعله كده علم ينتفع بيه. والدكتوره حنان ابراهيم
دكتوره حنان
انا موجوده يا دكتوره.
طبعا دكتور طارق اخي العزيز يعني، وكان اسم واحد، واكيد هنسمع كلام ممتاز. اتفضلي حنان، قدمي طارق.
أستاذنا العزيز أستاذ الدكتور طارق، the builder of the pediatric intensive care specialty in عين شمس University. هنبدأ بالدكتور طارق. خير بداية إن شاء الله لخير كلام من كل أساتذتنا العظام اللي هيتكلموا معانا النهاردة. أستاذ دكتور طارق يتكلم على ال guidelines of fluid resuscitation. اتفضل يا دكتور طارق.
بسم الله الرحمن الرحيم. في البداية بحب أوجه خالص الشكر للأورجنايزنج كوميتي our Professor Dr. Mahmoud المتيني, our Professor Dr. أشرف عمر, our Professor Dr. شهيرة, أختي العزيزة Professor Dr. منى الجنزوري, طبعا أخي العزيز دكتور مصطفى هدهد, وكوكبة عظيمة من أساتذة طب الأطفال. الواحد هيحتار يشكر مين ولا مين, لكن طبعا كل خالص الشكر والتقدير طبعا دكتورة منال حمد السيد, واختي الحبيبه دكتوره حنان ابراهيم, واخي العزيز دكتور هشام عوض. هي كل الشكر والتقدير انهم سمحوا لي ان انا اكون وسط هذه الكوكبه من طب الاطفال. هبتدي موضوعنا النهارده على fluid responsiveness and 6th guideline principle of fluid resuscitation. 8 years old female admitted to the ER with a picture of heart rate 108 per minute, respiratory rate 35 breaths per minute. She looks toxic and had upper respiratory tract symptoms a few days ago. They called for doctor of ICU. Dr. ICU doctors when came and examined our patient. He found that our patient heart rate 180 per minute, temperature 39.9 degrees centigrade, respiratory rate 32 breaths per minute, blood pressure 70/50, oxygen saturation 90% on warm air. She was quiet, tired, open eye, capillary fill 5 seconds. Let's analyze these data. Heart rate tachycardic 108 per minute. She was febrile, temperature 39.9, hypotensive, blood pressure 70/50, or prolonged capillary fill. Patient febrile, hypotensive, tachycardic, out of proportional fever, or prolonged capillary fill. Unfortunately, it is a picture of pediatric sepsis. Unfortunately, why? Because sepsis, in spite of great advance for management of sepsis remains the major cause of morbidity and mortality in the ICU. وفي 2018 كان عدد الحالات recorded with sepsis worldwide كان 19 million. 30% of these patients will develop septic shock. والmortality rate for septic shock in developed country range from 20 to 30%. And for developing country, it may reach 50 to 70%. According to Survivor Sepsis Campaign, management of septic shock should be done as soon as possible. في أول 5 دقايق لازم تشخص يعني sepsis و200 airway و200 IV line. في خلال ربع ساعة لازم تكون ركبت IV fluid, isolating saline 20 ml per kg أو is equivalent من الكلويد to be repeated up to 60 ml per kg. في خلال ساعة you have to start the antibiotic to correct the hypoglycemia. بعد ساعة reverse the condition. لو العين ابتدى يتحسن, الهارت ريت ابتدى يقل, blood pressure ابتدى يعلى, sign of hyperfusion ابتدى يختفي, الكابيلاري فيل بتاعتك ابتدت تبقى أحسن, يبقى احنا عندنا حالة fluid responsiveness ونخلي العين ده under observation في الاي سي يو. لو البلاد بريشر ما تحسنش والعين still hypotensive in spite of fluid therapy, you are facing a case of fluid refractory shock. According to Survivor Sepsis Campaign, لازم في أول 6 ساعات تكون وصلت لمرحلة إن السنتر فينس بريشر بتاعتك عالي من 4-8 ملم اللي هو مش مفانتل, 8 و12 اللي هو مفانتل. المين ارتيريا بلاد بريشر لازم يكون أكتر من 2 ستاندرد ديفيشن above the mean for his age and sex. اليورين اوتبوت يعدي نص ml بالكي بر اور. الميكس فينس اكسسيتريشن تتراوح بين 65 ل 70%, والسيرم لاكتيت يبتدي يقل. This is you have to reach in the first 6 hours. لو احنا وصلنا بالايرلي جول دايركت ثيرابي لهذه المرحله يبقى congratulations you save your patient. لو انت فشلت في خلال 6 ساعات الاولانيين توصل المرحله دي you are facing a real problem. IV fluid remains the cornerstone for management of sepsis. لأن مع السبسس بيبقى فيه decrease التيشو, بيبقى فيه decrease intervascular compartment, وهتشعر ببرفيوجن وهايبوتنشن وelevated lactate. فمينيمم 30 ml per kg of corticosteroid or its equivalent for colloid should be given as soon as possible. This is grade 1B عشان في management of sepsis. They prefer to use crystalloid عن الكولويد ودي برضه محتاجة grade 1B. But this is first step في management of sepsis. الحقيقة في العيان اللي احنا قلناه نرجع له تاني، احنا follow this protocol. We give 30 ml per kg normal saline over half an hour to be repeated by another 30 ml per kg over 1 hour. بعد الساعة لاحظنا إن الساين والكولابس disappear، السي في بي بتاعنا عالي ل7، الكابيلاري ريفيل تايم اتحسن، لكن فوجئنا بالآتي إن الريسبيراتوري ريت تعلى، وصلت 72 بريث بير مينت، والبلاد بريشر ستيل لو 70 over 40، والشيست ابتدينا نشوف بايلاترال كرابس، وعملنا اكس راي شفنا البيكشر بتاعت اكيوت بالمونري اديما. اعتقد ان احنا بدون شك بنشوف الحلقه دي كتير جدا. العيان بيطلع لنا من الاستقبال اللي عنده سيبسيس بقى بيكشر اوف اكيوت بالمونري اديما، ودايما بنلوم النواب، بنقول النواب ادوا محاليل بسرعه او ادوا كميه اكتر من محاليل، عشان كده العيان دخل منهم في اكيوت بالمونري اديما، ونقول لا مش المفروض يحصل كده، وان احنا لازم ندرب النواب على استخدام المحاليل بطريقه صح. لكن العيان ده احنا ادينا محاليل، المحاليل اتخذت بالصوره صح في وقت صح، ومع ذلك العيان دخل في اكيوت بالمونري اديما. الفلويد ثيرابي the first step for resuscitation، وانكوركت هايبوفوليميا هتعمل inappropriate use of vasopressor، وده ممكن تزود الاورجن هايبرفيوجن تيشو اسكيميا. On the other hand ان overfluid ممكن تدخل العيان ده في بالمونري اديما. يبقى الفلويد ثيرابي should be given with great precaution, with great skill, under بروتوكول معين عشان guided بحاجه اسمها fluid responsiveness. قبل ما تدي IV fluid, please ask yourself, what is the goal of IV fluid therapy? Is the goal to increase blood pressure? Or how to increase? السؤال الثاني, is it true that all your patients will improve blood pressure with IV fluid? Is it true? Well, some patients will improve, or some patients will not improve. Some patients will be fluid responder, and other patients will be fluid unresponsiveness. لو العيان ده fluid unresponsiveness, for how long you will give the fluid and امتى هتوقف المحاليل بتاعتك. طب لو العيان ده volume overloaded ومسبتك, هل there is indication ان انا ادي IV fluid؟ هل العيان ده ممكن يكون fluid responsiveness رغم ان هو volume overloaded؟ حقيقة كيكوني سنة 2015 حقيقة أتحفنا بمقالة شديدة الأهمية. قال لك إن 50% من العيانين بتوع الآي سي يو مش هيتحسنوا على الآي في فلويد، ودول فلويد unresponsiveness. بالعكس، إن أنت لو اديت فلويد أنت هتسوي العيان ده وتدخله في أكيوت بالمونري إديما. وقال لك إن vasopressor والإنتروب should be used very early عشان تمنع الأورجان هايبرفيوجن وتلمت التيشو إديما. وقال كلام مهم جدا، قال لك ان clinical examination والفيتال ساين are very poor predictors للفلويد responsiveness. ما اقدرش اعتمد على الكلينيكال examination والفيتال ساين عشان افرق اللي عنده فلويد ريسبوندر ولا فلويد نون ريسبوندر. طب قال لك يعني ايه فلويد ريسبونسفنس؟ قال لك فلويد ريسبونسفنس اللي هو العيان اللي هيزيد الستروك فوليوم بتاعه من 10 ل 15% لو خد من 20 ml بالكيجي كسرات او اس equivalent بالكولايد. وان increase في stroke volume does not necessarily associate with increase في blood pressure. وان fluid responsiveness ملهاش علاقه بالفلويد ستيتس، يعني العيان الاوفر هيدريتد ممكن العيان يكون محتاج ياخد فلويد. يبقى فلويد ستيتس مش معناها ان العيان ده مش هيبقى محتاج فلويد، ومش معناها ان العيان ده مش هيستجيب على الفلويد ثيرابي لو هو دخل في سيبسس. طب تعالى نتكلم بهدوء. يعني ايه؟ يعني العيان ده عنده شوك، عنده تيشو هايبرفيوجن وديكريز الكارديك اوتبوت. وفلويد ادمنستريشن هتابجريد فوليوم لو زودت لي ستروك فوليوم وزودت الكارديك اوتبوت. وانكريز ستروك فوليوم يزود اند ستروك فوليوم وسيركيوليشن بلاد بريشر، وبالتالي هتحسن الفوليوم اكسباندرز. ولو فوليوم ما زودليش الستروك فوليوم يبقى هنا هيبقى عندي مشكله ان الفلويد ده والاكيوميت في السيركيوليشن والعيان هيخش مني في بالمونري اديما وتش هايبوكسيا. تاني حقيقة تانية مؤكدة إن العيانين اللي عندهم سيبسيس 54% منهم عندهم دايستوليك ديسفانكشن و23% عندهم سيستوليك ديسفانكشن. معنى كده لو أنا اديت اجريسيف فلويد ثيرابي العيانين دول هيخشوا مني في اكيوت بالمونري اديما. يبقى بالتالي القانون الشهير اللي احنا ماشيين عليه إن هو aggressive fluid resuscitation is a cornerstone for resuscitation of the patient with severe sepsis and septic shock. هذا القانون should be revised. مش كل العيانين اللي عندهم septic shock هيتحسنوا بaggressive fluid therapy. Only 50% هيبقى fluid responsiveness و 50% هيبقى fluid non-responsiveness، والعيانين ال 50% التانيين دول هيخشوا منك في acute pulmonary edema لو انت ما خدتش بالك. في استخدام فلويد مش لازم يستخدم كده هاب هازارد. اي عيان مسبتك ادي فلويد 20 ام ما تحسنش 20 ام ده عيان ده ممكن يخش منك غصب عنك في acute pulmonary edema. انما لازم في كونسبت اسمه فلويد ريسبونسفنس وفلويد ان ريسبونسفنس. لازم نعرف مين هو العيان اللي ممكن نديله فلويد ومين العيان اللي احنا لازم تستوب وستارت الانتروب والباسبريسور. يبقى السؤال الثاني to give or not to give fluid. A fluid challenge is mandatory عشان نعرف مين هيستجيب من الفلويد بتاعك. وزي اتفقنا قلنا الفلويد البيشنت هيعتبره فلويد ريسبونسفنس لو زاد الستروك فوليوم بتاعه من 10 ل 15% لو خد 20 ml كريسايد او اس ايكوفالنت بكلويد اوفر 15 minutes. وان البيشنت اللي عنده سيستوليك وديستوليك ديسفانكشن ما تحاولش معاه، العيان ده هيبقى فلويد ان ريسبونسفنس حتى لو هو انترفاسكولار ديبليتد. طيب هل الكلينيكال ساينس والفيزيكال فايندينج از انف تو دايجنوز الفلويد ريسبونسفنس؟ وهل الحاجات العاديه زي السي في بي والترا ساوند ممكن تساعدنا في الموضوع ده؟ زي ما قلنا ان الكلينيكال ساين والفيزيكال اكزيبيشن ممكن تقول لك عيان عن تشر هايبرفيوجن، لكن مش هتعرف ديسكريمينيت بين فلويد ريسبونسفنس وفلويد ان ريسبونسفنس. السي في بي نورمال سي في بي من 4 ل 8 ملم ميركوري في العين الميكشوال بانتل ومن 8 ل 12 في الميكانيكال بانتل. واللو سي في بي معناها هايبرفوليميا او ديكريز فينوس تيرن، وهاي سي في بي معناها اوفر هايدريشن وانكريز فينوس تيرن وهاي صاد هارتفيليا. ده الكلام اللي احنا بنحفظه وبنحفظه للناس. لما يقل السي في بي يبقى انت عندك هايبرفوليميا او ديكريز فينوس تيرن، ولما يزيد السي في بي العيان معناه اوفر هايدريشن انكريز فينوس تيرن. السؤال هل الكلام ده حقيقي؟ هل الكلام ده حقيقي، بس هل ده ابلايد على كل عيانين؟ لا. الCVP في very good correlation between CVP و pulmonary artery occlusion pressure. This is true. وفي relation كويسة بين الCVP و ventricular and systolic volume. This is true. وaggressive fluid therapy دي مقالة منشورة في البريتش ميديكال جورنال سنة 2018 بيقول لك إن aggressive fluid therapy عشان نحقق central venous pressure أكتر من 8 has been promoted as a standard care for management of patients with sepsis and septic shock. ستوب. لكن في الاخر قال لك ان recent clinical trials have demonstrated that this approach does not improve the outcome of patients with severe sepsis and septic shock. كلنا كنا بنحاول وبنعلم ولادنا ان احنا ندي محاليل عشان ترفع السي في بي بتاعتك ل 8، وبالتالي انت كده عندك جود انترفاسكولار فوليوم وجود ستروك فوليوم، انت ما عندكش تيشو هايبرفيوجن ولا هايبوكس ولا تيشو هايبوكس. بس الكلام ده مش حقيقي في كل العيانين. وفي مقالة ثانية في الكريتيكال كير زي 2017 بيقول لك إن positive fluid balance مع elevated center pressure are associated with increased mortality. بيقول لك لو أنت اديت فلويد ورفعت السنتر فينس بريشر لأرقام كبيرة 10 أو 12 وسبتها عالية لمدة 4 أيام معاها هاي mortality rate. ليه؟ بيقول لك ان العينين دول بيحصل لهم نوع من الفازو كونستريكشن في رينال ارتري وبتعمل لهم رينال شات داون ورينال اسكيميا. فالسنتر فينس بريشر
دكتور طارق الوقت بس الفت نظر حضرتك للوقت.
ماشي يا حنان، امشي يعني؟
لا ازاي يا دكتور طارق، حضرتك منورنا.
السنتر فينس بريشر از ا جود تشالنج عشان فلويد ثيرابي، لكن مش لازم نتاخد عليه. يعني كل الدراسات على 100 دراسه have been published and demonstrate ما فيش اي علاقه بين السي في بي وفلويد responsiveness in various clinical studies. again ان زي ما احنا قلنا ان استخدام الفلويد ثيرابي كده عشان تحسن الانترفاسكولار كومبارتمنت وتحسن التيشو برفيوجن، هذا الكلام should be revised. again السي في بي كجايد لاين عشان تعرف ان العيان ده عنده جود تيشو برفيوجن ولا لا برضه should be revised. مش هو ده الايديال في كل الحالات، ممكن يكون مفيد في بعض الحالات لكن بعض الحالات مش مفيد. الالترا ساوند من الحاجات الجميله جدا. الالترا ساوند بيقيس الانفيريور فينا كافا كولكسبيليتي والديستنتابيليتي والديامتر. لو الانفيريور فينا كافا ديامتر بتاعتي من 1 ل 3 ده نورمال، لو اقل من 1 سنتيمتر ده عندها فلويد ريسبونسفنس، ولو اكتر من 3 سنتيمتر ده فلويد نون ريسبوندر. الباسيف ليجازنج تيست طبعا دلوقتي هي ماشيه اهم ميثودز عشان نشخص الفلويد ريسبونسفنس which is very simple and very easy. بنحط عندها في سيمي كامبات بوزيشن وعين بسرعه بنوطي دماغه ونرفع رجليه. لو العمليه دي associated with increase stroke volume بمور than 15% يبقى العيان ده عنده فلويد ريسبونسفنس، لان بتحرك الفلويد من اللور كومبارتمنت، بتحرك الفلويد اللور كومبارتمنت للشاست، فاذا زي ما يكون مادي محاليل من غير مادي محاليل. فالباس ريجرايزنج تيست عندها سنسيتيفيتي 97% وسبيسيفيستي 94% عشان تشخص فيها الفلويد ريسبونسفنس ولا فلويد نون ريسبونسفنس. It is a simple من غير ما تدي اي محاليل، من غير اي ريسك على العيان، انها طبعا ريفرسبل، مجرد ان انا اعدله تاني كل حاجه هترجع مكانها وكل الضغوط هتتظبط تاني. لكن it is a very simple. لو احنا علمنا الولايه بتاعتها ونقيس لهم ستروك فوليوم قبل وبعد ونعمل باسيف ليجرايز تيست، يبقى قبل ما تدي محاليل بسهوله هتعرف مين هو فلويد ريسبونسفنس ومين هو فلويد ريزيستنس. لازم نعرف ان ريسبونس فلويد الشارت ليفت، يعني لما بدي محاليل مش نهايه الدنيا، المفروض ان بعد ساعه اكون ابتدي بقى لان التراب والباسبريسو. يعني استخدام المحاليل دي خطوه اساسيه عشان تطلع العيان من الكولابسنج ستيج، لكن مش بعديها اقف، لازم ابتدي استمر بقى واحافظ على الضغوط اللي انا حققتها، لانه وانس بعد نص ساعه او ساعه الفلويد تاثير الفلويد ده هيروح والعيان هيبقى كولابس تاني. فلازم ابتدي بسرعه استخدام الانتروب والفاسبريسو بعد ما ارفع له ضغطه. بيشن اونلي ريسيف فلويد لو هو هيمودايناميك بنفيت، لكن لو هو مش هيستفيد منها يبقى ملهاش اي معنى للفلويد ثيرابي. وزي ما اتفقنا ان هاي سي في بي ممكن يعمل لي اورجان هايبوبرفيوجن ورينال اسكيميا. يبقى الستيشن there is no ideal station fluid. ان الستيشن فلويد ممكن تعمل لي pulmonary edema وانتستيشن edema. colloid is a volume expanders لكن hemodynamic effect may be minimal. normal saline ممكن تعمل لي hyperchloremic metabolic acidosis. albumin safe but very expensive. hypertonic solution proved to be safe but not yet proved you are used. يبقى قبل ما استخدم فلويد لازم اعرف ان more than 50% ICU will suffer from atherogenic harm. too little fluid ممكن تعمل لي hyperperfusion و over fluid ممكن تعمل لي acute pulmonary edema. even for normal healthy volume fluid responsiveness does not mean fluid. Fluid should be given only hypertensive والعيان عنده sign of hyperperfusion. fluid resuscitation محتاجة great skill مش أي حد ممكن يستخدمه من غير تركيز. يبقى قبل ما أدي فلويد لازم أسأل نفسي should I give this patient more fluid? Will this patient will improve hemodynamic and response fluid? Does the fluid bolus likely to augment the cardiac output and improve tissue perfusion? Does my patient need fluid and how much and for how long? Thank you very much.
شكرا دكتور طارق على المحاضرة الجميلة دي، وهننتقل للنكست سبيكر ان شاء الله دكتور هشام عوض، استاذ طب الاطفال وحديثي الولاده ورئيس القسم السابق واستاذي العزيز. هنسمع محاضره منه على السنترال لاين ريليتد بروبلمز. اتفضل يا دكتور هشام.
بسم الله الرحمن الرحيم. شكرا لإدارة الكلية وإدارة الجامعة والزملاء والقائمين على هذا المؤتمر، والدكتورة رانيا إبراهيم الدينامو بتاع هذا المؤتمر. هنتكلم النهاردة على complication of lines in neonate. What is meant by central line? Central line بنستخدمها كتير جدا. It is an intravascular catheter that terminate at or close to the heart or in one of the great vessel which is used for infusion, withdrawal of blood or hemodynamic monitoring. ماليش دعوة بالارتيريال دلوقتي، لكن الجريت فيسل الكونسيدر سنترال هي superior vena cava, inferior vena cava, brachiocephalic, internal jugular, subclavian, الإلياك, common femoral والumbilical neonate. Central venous lines and catheters necessary in neonatal intensive care population to provide adequate nutrition and pharmacological support, maintaining access with peripheral IV catheters. This population is often difficult and impractical. When prolonged IV support is required, a central line is typically placed, بالذات في extremely low birth weight neonate where parenteral nutrition is a must to let them grow adequately. In addition, the use of peripheral line, which is associated peripheral cannulae, which are associated with the painful needle sticks and provide this pain stimuli will increase the pulmonary pressure, and we have seen patients to succumb simply by the prick of inserting a peripheral cannula if they are suffering from pulmonary hypertension. Central venous catheter, it allowed increased survival rate of extremely low birth weight infants, and such use is not without danger, so it is exemplified by a double-edged sword. It has got a beneficial effects. It allows increased survival, but it has got a lot of pathological side effects. And central venous line allows us to use hypertonic solutions, hyperosmolar solutions, which are frequently needed to give adequate calories to these babies to allow them to continue an extra uterine growth, adequate extrauterine growth to cope with the needed postnatal growth. Central venous catheter could be classified into peripherally inserted central catheter, or it is called the PICC lines, umbilical venous catheters, non-tunneled, tunneled, and implantable ports, and all of these could be used in the neonates. The most frequently used are the PICC lines and the umbilical venous catheters, and these are what we mean by tunnel catheter, where the opening in the skin is different from the opening in the vein, but at any rate they should enter, they should end here in the junction between the vena cava and the heart. So the tip of the catheter, whatever the type of catheter we use, the tip of the catheter should be at the junction of the vena cava and right atrium, whether it is the superior vena cava or the inferior vena cava. When we are using we will not discuss the umbilical arterial, but when we are using the umbilical venous catheter, after insertion, an X-ray should be done with proper positioning of the baby. So the position should be when inserting an umbilical venous catheter. The proper position are the legs straight and the arms are above the head. And the tip of the catheter, umbilical venous catheter, should be between the 8th and 9th thoracic vertebrae outside of the cardiac silhouette. Lines with tips in the ductus venosus can be used. Intracardiac line should be pulled back. Lines with tips in the liver should not be used, and lines may be pulled and used for 24 to 48 hours till they can be replaced. A lateral view. Lateral view, there are occasions when two radiographic views and additional lateral view are helpful in determining the position. This is especially true to determine the proper position of umbilical venous catheter, and if there is any doubt of the line tip, a further view should be taken. So when inserting an umbilical venous catheter, remember the target is the 9th to 10th thoracic vertebrae, the level of 9th thoracic vertebrae just above the hemidiaphragm and just below the heart. This is the ideal location, and look at the place, look at the diaphragm, and look at the tip of the catheter. The recommendation for the umbilical catheter: if remove and do not replace umbilical venous catheter if any sign of infection and thrombosis are present, and the only indication to replace a central venous catheter, a central umbilical venous catheter, is the catheter malfunction when there is a fracture of the hub or a perforation of the catheter. You should replace it, but if there is thrombosis or infection, it is not a good idea to replace it. And here the target between T8 and T10, here is the target in the anteroposterior, and in the lateral view, look at the course of the catheter as should be explained. It will be explained. So the catheter is inserted in the umbilical vein stump. The umbilical vein, it passes in a curve in the body in a cephalic direction within the falciform ligament, angling posteriorly. It is angling posteriorly to join the portal sinus, and then afterwards, entering the portal sinus, it enters the ductus venosus, and then the subdiaphragmatic vestibulum to join the inferior vena cava. And here is the illustration of the trajectory. Note the direction of the catheter with the curvature to the right and pointing to the right atrium. This is the ideal position in the subdiaphragmatic vestibulum or in the ductus venosus, but we should be sure that the catheter is in this line and not out of this line. This is the ideal position of the catheter, just above the diaphragm and in line, and look at the curvature, slight curvature to the right side. Here the ultrasonographic presentation of the umbilical vein and the ductus venosus inferior vena cava. Here it is a catheter which seems to be in good position below the level of diaphragm and pointing to the base of the right atrium on X-ray. But when doing the ultrasound, this apparently adequate position is not properly in position, and it is entering the liver parenchyma. This is an ultrasound. It is entering the liver parenchyma, and it is not in the inferior vena cava. Look how it's deceiving to have a single film, a single X-ray film, and a posterior anterior view. Apparently, this is an adequate position, but performing an ultrasound, the tip of my catheter is away from the inferior vena cava and the vestibulum, and it is in the liver parenchyma, and it could be associated with a multitude of complications. Here in this views, it is evident that my catheter is not in the proper position, and it is entering the right portal artery in the A, and the left right portal vein in the A, and the left portal vein in the B. In this X-ray, again, the position is not an ideal one, and when performing the ultrasound, it was shown that it is entering the liver with a subsequent development of fluid accumulating in the abdominal cavity due to the leakage from the tip of the castor, which was in the liver parenchyma, and then extravasated into the peritoneal cavity, leading to ascites formation. In this X-ray, the line curve away of the heart and the tip does not point to, there is no the typical curvature, and does not points towards the atrium. On sagittal ultrasound, the IVC in this baby cross the anterior portal sinus and entering in a vein. It is not another branch of the vein. It is not directly towards the inferior vena cava. In this slide, we will see how in each different position, what's the position, what's the radiological landmark, and what are the potential complication, the clinical sign. So in the subdiaphragmatic vestibulum, radiological position is between T8 and T9 outside the cardiac silhouette, pointing towards the right atrium. The potential complication in this position, as with any castor, is the infection and venous thrombosis. Clinically, these will manifest by signs of sepsis, and thrombosis is often silent. In the hepatic vasculature and parenchyma, the radiological position is T8 and T9 or below. It is outside of the cardiac silhouette, usually entering the right or left portal vein and deviating from the course to the right atrium. The extravasation will lead to hematoma, abscess formation, or ascites. Venous thrombosis can lead to obstruction of splanchnic drainage, and clinically there will be abdominal distension, hemodynamic instability, ascites, and later on development of portal hypertension, lobar necrosis of the liver, and splenomegaly. If it enters the right atrium or the left atrium, the tip will be above T8 to T9, projecting over the inferior border of the cardiac silhouette, and there may be pericardial effusion, tamponade, dysrhythmia, and intraatrial thrombosis as potential complication to its abnormal site. And this clinically will manifest by sudden unexpected deterioration with hemodynamic compromise, tachycardia, and abnormal ECG. If it enters the pulmonary vein, the tip will be above the T8, T9, and overlying left lung field. There may be pleural effusion, and there will be respiratory compromise. Other abdominal vessels like superior mesenteric vein, the umbilical venous catheter doubles back and enters into the superior mesenteric vein. There will be venous thrombosis with abscess formation, and clinically, there will be abdominal distension, hemodynamic instability, and ascites with the potential of portal hypertension, lobar atrophy of the liver, and splenomegaly. And these are abnormal positions. This is a normal position of the umbilical castor, and pointing, look at the posterior angulation when the umbilical vein will join the portal sinus and pointing towards the heart. And these are examples of abnormal position angulating into the right portal vein, a schematic presentation and X-ray in the left branch of the portal vein. And here it enters, it curves down and enters the superior mesenteric vein with resulting hyperemia of the intestine and abdominal distension. In this condition, the left pulmonary vein, or it may enter, it continues straight and enter the inferior vena cava. In this illustration, we can see the depth of the castor, which should be used while applying, when putting an umbilical venous castor, and here's the formula. We can return to it afterwards. When the umbilical castor is too deep, beyond this depth, it may enter it may enter into the superior vena cava, it may enter to the right ventricle, it may enter the left atrium and left ventricle, and even in the pulmonary veins with all the complications which can occur. In this X-ray, the casters entered into the right atrium and then in the superior vena cava, and this is entering into the internal jugular vein. And in this, it enters the pulmonary vein. Injection in this site can have severe pulmonary complication, as it will be shown later on. When it enters too deep in the right atrium, it will pass through the foramen ovale and it will enter into the left ventricle vein, and here it called into the left atrium, and this will be associated with great potential for arrhythmia, thrombosis, and extravasation. Here, when the caster was left in place, perfusing the left pulmonary vein, a venous infarction occurred in the lung with involvement of the left upper lobe as a result of venous infarction, and use it. Thrombosis. Thrombosis is a frequent, not infrequent complication of umbilical venous catheterization. In this echocardiography, a sheath-like thrombus is seen in the near the umbilical venous catheter tip, and here a right atrial thrombus developed as a complication of the umbilical venous catheter, and this in this video we can see the thrombus, the intra-atrial thrombus complicating the presence of umbilical venous catheter. So there is a risk of significant morbidity and occasionally mortality associated with the use of umbilical venous catheter, and the ideal position for the tip of umbilical venous catheter is subdiaphragmatic vestibulum, which on X-ray is usually at T8 to T9 outside the cardiac silhouette and pointing to the right side of the base of the heart. Even lines that fit this criteria may be in unsafe position. Umbilical venous catheter below T9, which appear to be following the correct route, may be suitable for short-term emergency use, but are greater risk for extravasation. Lines that do not fit these criteria and do not appear to be following the correct route may be misplaced within vessels that penetrate the liver substance and causing hepatic injury and extravasation. Ultrasound can be useful in clarifying umbilical venous catheter tip position and identifying misplaced lines. Teaching trainees to identify umbilical venous catheter position on ultrasound may improve the placement. When using the PIC line, we can use it either in the upper limb, in the scalp, and we should have an initial X-ray with a proper positioning of the baby, proper position with both shoulders. When doing an arm PIC line, both shoulders should be abducted to 30 degrees while performing the X-ray. And there are occasions when a second radiographic view should be done to show the coiled or turned line, and if there is any doubt, do a second line, and sometimes we resort to do opacification and injection if the tip of the line is not properly in place. The limb position, it is essential, as we have said, to have a proper limb position. It has been shown that upper limb PIC line can move up to 2 to 3 vertebral body on abduction and adduction of the arm. And here an example of how movement of the arms, this has been fixed in a PIC line, and after fixation, when the arm is adducted, the central line is becoming too deep. So the proper position is to do the X-ray is with a 30-degree abduction, and according to the vein, we can see in this diagram how the movement of the limb will result in the displacement of the tip of the catheter. The ideal position when أفندم
الوقت بس يعني.
حاضر. The ideal position, the tip of the catheter should be situated at above the T4, the force, and above the carina, in the X-ray, abnormal depositions of the central line will be curved and will be associated with complications. This is a properly positioned PICC line in the junction between superior vena cava and right atrium. Do not forget, never use syringe less than 10 centimeter for flushing or medication administration. Avoid twisting and do not flush against resistance. The tip can migrate. In this condition, the tip migrated enters the pulmonary artery, and with injection the dye, it is the dye accumulated in the left pleural cavity. This, when the tip is not in the proper position, it can be near central or non-near central. Both near central and non-near central could be used in emergency situation, but do not administer hyperosmolar solution because a great risk for thrombosis and complication can occur. When a near central, this is an extravasation from the near central and sloughing, and this is the intralipids, the IV lipids extravasating through a sloughed vein occurring as a result of abnormal position. This is too deep one, and examples of deep positions of the central line. When inserting in the lower limbs, do not forget that there are rules in the lower limb inserting the PICC line in the lower limb. The PICC line in the lower limb, when inserted, should cross the middle line, especially when it is inserted in the left side. It should cross the middle line at the lumbar 5 vertebrae, and the tip should be at between T9 and T11. If it doesn't cross the middle line in posterior anterior view, this may signify that it enters the vertebral veins, and when it enters the vertebral vein and injecting the solution lead to severe neurological complication. And in the lateral view, the PICC line inserted should be in front of the body of the vertebrae and not in front of the body of the vertebrae as in this line after crossing the middle line. If not, it can enter this vertebral vein, and when you're injecting, there will be paralysis. There may be paralysis of the lower limbs and severe myelopathy and encephalopathy. Here it is clear how it crosses, and here it is my vein didn't move anteriorly to the vertebrae, but it passed in the vertebral vein, leading to the complications. And here there is no crossing, and it follows the festooned picture of the vertebral veins. These are examples of abnormal positions. If you have got any doubt, do another X-ray. There may be a knot like in this position, and these are the landmarks, the T4 and T9. T4 for the lines inserted through the upper limbs and not to exceed the T line in umbilical, and those in the lower limbs. What's the value of second look? In this apparently a good positioned umbilical catheter. In the lateral view, it is not in good position. It is away from the normal trajectory of the catheter. Look at these. Here is the proper position, and look at these catheters. Catheter appearing in the anteroposterior view adequately in line, but in the lateral position it's curved and angulated, and it's the liver substance. Here a PICC line inserted apparently adequately, but it is entering here from signifying it is an arterial, not a venous one, an arterial course which will be associated with all the complication arterial line. And here in this condition, the catheter is crossing the middle line, but the tip is not in the proper position. So we will pass through this, and we will these are a list of complications of the central line insertion: pneumothorax, hemithorax, arrhythmia, infection, mediastinal hematomas. Infection are extremely important. Two types of infection: castor-related bloodstream infection and central line-associated bloodstream infection could be related to the skin, to the hub, or contaminated infusate. 13 regulations for decreasing this occurrence. The first is education. It is the most important. Educate, remind them regularly assessed, have a team specialized, respect the appropriate patient nursing ratio, and have a written bundle for prevention, for during the insertion and for the maintenance to avoid the infection of the central line, including the covering with and the change of the covering of the central line, whether we are using a transparent one, which should be changed not more than every 4 days and not less than once a week. And if you are using a gauze covering, it should be removed, changed every 48 hours, and the use of anticoagulant to avoid thrombosis. Effusion, pericardial effusion. I will stress upon the pericardial effusion because it is a very dreadful complication of the central line insertion. Clinically, there is sudden deterioration, swinging heart rate, fluctuating blood pressure, and desaturation, and presence of pulsus alternans with great mortality between 62 and 100%. Usually it occurs after 3 days, and the patient will present by sudden hemodynamic collapse. It results from migration of casters, movements of the limb. So many authors suggest the use of bio-occlusive dressing without using Steri-Strip to avoid such movement, and do X-ray 2 times a week to monitor the position of the tip catheter. In this umbilical catheter, you can see how it curved, and when it curved, it leads to pericardial effusion and tamponade. Sometimes X-ray will not be enough, and the same complication can occur with internal jugular, and internal jugular associated with pleural effusion and interlobar effusion, as seen in this film. With the infusate, how to confirm it. If you withdraw this infusate, look at the glucose concentration and the lipid concentration be very high, and it will need to reposition. That's my last comment. Look at the ESPGHAN guideline on pediatric parental nutrition complication, very illustrative, and look at the recommendation. The yellow are the recommendation to avoid the infections, the green are the recommendation to avoid thrombosis, and the blue are recommendation to avoid the catheter breakage and fluid extravasation. Thank you for your attention and have a nice day.
شكرا دكتور هشام على المحاضرة البراكتيكال القوية اللي أكيد كل شباب المحضر هيستفيدوا بيها. ويسعدنا إن احنا نسمع دلوقتي دكتورة إيمان زكي في محاضرة عن الانوفيشنز in child psychiatry. اتفضلي يا دكتورة إيمان.
Okay, 1 minute. Professor Mona Ganzouri, the head of the Pediatric Department, Faculty of Medicine, Ain Shams University, and my dear colleagues, chairpersons, my professors, and dear colleagues. It's my pleasure and an honor to participate in the annual congress of our faculty and our department. The topic I will discuss today is entitled Innovation in Child Psychiatry. First, I would like to declare no conflict of interest, and the objectives of my talk include addressing the need of innovation in the field of psychiatry and mental health, highlighting the different domains of innovation in psychiatry and mental health, showing the integration between innovation and the ordinary to maximize the benefits of healthcare and minimizing its costs. Mental illness affects tens of millions of people yearly. It is both costly and prevalent, but researchers are working hard to make it history by introducing drastic lifestyle changes in the lives of their patients, discovering the latest diagnostic techniques and the most beneficial therapeutic modalities with minimal side effects. Ordinary and innovation. These two words seem incompatible and contradictory, but they are well integrated and complementary from the clinician point of view, especially those working in the field of child psychiatry. Luckily enough, the boring life of a clinician, starting from being an undergraduate with exhausting learning demands, to the hard life of a clinician who is devoted for treating his patients, taking care of his interests, as well as covering the concerns of their caregivers and being up to their expectations, breed innovation. Whoever can withstand ordinary can be innovative. Innovation will result from the accumulation and the burden of the ordinary and routines. Ignorance, discrimination, and stigma represent the most common ordinary challenges facing children with mental disorders and their caregivers, as well as their child psychiatrist. This makes the sparkle of innovation more crucial and priceless. Research over the last 30 years has given a great hope and optimism for those with mental disorders and their families. Better understanding of psychiatry and human behavior is growing regarding both neurochemistry as well as brain function and dysfunction. So, safer, effective medications and therapeutic modalities are going to be available. Our target is to deliver personalized care, prescribe evidence-based medications, offer effective psychosocial intervention to our patients to empower their abilities to enjoy more productive lives with a better quality of life in all its domains. في الحقيقة, innovation in child psychiatry include all its aspects from psychopathology to recovery. It is important to know that psychopathology of mental disorders lie in the interaction or interplay between nature and nurture, or biological factors and environmental factors. It is very important to remind you that all mental disorders are multifactorial in etiology, meaning interacting multiple factors between nature and nurture. We can't do anything about the genetic susceptibility once we have the baby. And the genetic susceptibility is very difficult because it is in the form of affection of many genes. So what we can actually do is to manipulate the environmental conditions to suit the patients and minimize the susceptibility for mental disorders, especially for those with genetic predisposition. So, understanding the interplay between nature and nurture, biological factors, and environmental factors will help us greatly to modify the diagnostic techniques to find the most accurate and advanced techniques. Especially, we are dealing with mental disorders which are diagnosed mainly by clinical criteria. Then, discovery of many advanced psychotherapeutic modalities. I can give you an example to imagine how can we improve the cognitive behavior therapy. In the old days, we used the restraining of our patients to deal with them during their aggressive attacks. Now it is forbidden to use that except in emergency situations, and instead we deal with cognitive therapeutic intervention, dealing with teaching our patient how to learn to solve their problems and control their anger. And lastly, but by no means least, finding the most efficient and effective psychotherapeutic medications with the least pattern of side effects. Actually, we are in the era of COVID-19 pandemic. Was it an international disaster or a blessing? As the whole world moves forward from COVID-19, it is important to highlight the noteworthy achievements that occurred at a lightning speed with a worldwide remarkable progress in responding to this pandemic. We faced the pandemic with the integration between ordinary and innovation. It is well known that the need is the mother of innovation, and the COVID-19 pandemic was a typical example of the solidarity of this fact. Now, what about these innovations? It is very important to notice that all of a sudden, millions all over the world needed psychiatric support, whether the patients, their families, or those afraid to catch the infection. It is very important to say two examples about the number of psychiatrists in two of the most advanced countries or the most developed countries economic-wise. In USA, the total number of psychiatrists is about 33,000. And the number of child psychiatrists is 1/4 of this total number. While in China, the total number is 20,000 and the child psychiatrist is 1/40 of this number. So we were facing a dilemma. How can we meet the needs of our patients and those afraid from catching the infection with this limited number of psychiatrists, even in the most advanced countries? The world started to develop many lines to face such needs in COVID-19 pandemic, included establishment of online groups for mental health care workers, establishment of internet support groups for patients, applying infection control protocols dedicated for mental health services, applying new protocols for ward management, taking in consideration the PPE, considering home hospitalization whenever possible, using mobile mental health clinics with mobile applications to serve our patients and those afraid to catch the infection 24/7, and using the telepsychiatry at community health clinics, giving the possibility for general practitioners to counsel specialized psychiatrists anywhere, anytime. Luckily enough, most of the journals opened their internet information database for the whole world freely to help the progress of the academic research, and also to help the clinicians all over the world to improve their skills and their knowledge to help their patients or serve their patients. Also, most of the conferences as ours now has become virtual using the online platforms, and this increased the attendee numbers and facilitates their gain of new knowledge and communication skills, and as well reduced remarkably the cost of organizations, traveling, accommodations, etc. Also, these new lines of dealing in psychiatry necessitate necessitate that we must lay emphasis on the ethical consideration as well as legal issues. Legal issues in providing mental health care service during a pandemic must be taken in consideration, as we said. Procedures for taking consent for video or telephone consultation, drug prescription, or taking home supplies of medications must be well planned and delivered under strict supervision with fulfillment of all ethical consideration. Taking care of homeless children and those in foster care is very challenging at the time of national crises and must be covered by national health authorities as well as NGOs. Ethical challenges in the context of a pandemic and mental health must be well studied to find solutions for the expected problems with applicable legal alternatives. Setting hospital admission priorities, treatment availability for those in need, putting guidelines to deal with the future epidemics, natural disasters, or any unexpected national or international crisis have become crucial. Taking home message include highlighting the advances in psychiatric research over the past 30 years and the fact that it paved the way for hope and optimism for those suffering from mental disorders and their families. On the other hand, the better understanding of the brain and its function and dysfunction with its neurochemistry is the main concern of all researchers all over the world now, especially those in the field of psychiatry and behavior, in order to provide those in need with much safer and effective modalities to deal with their problems and enjoy much better quality of life with improved productivity and independence, collaborating what is innovative with what is ordinary. Ending my talk with a sentence of Emily Dickinson, which is an American poet. She said that hope is the thing which feather that hope is the thing with feathers that bursts the soul and sings the tune without the words and never stops at all. Thanks a lot for your attention. Now it is my pleasure to introduce my dear colleague, Professor Iman Munir, the head of Pediatric Diabetic Clinic in our department. She will tell us a very interesting talk about recent advances of diabetes mellitus type 1.
بس عاوزة أقول حاجة قبل ما إيمان تبتدي. أنا بشكر الدكتورة إيمان زكي على very cheerful slides.
لينا عارف صح
والكونتنت حلو قوي. اتفضلي يا دكتورة
Thanks
إيمان.
a lot. Thanks a lot, my dear colleague and the head of the pediatric department.
دكتورة إيمان منير.
I have the honor to participate in the Medical Congress of Ain Shams University, and I would like to thank the organizing committee, Dynamo, Dr. Rania, and my dear professor, Ustaza Mona Kanzouri, على النجاح الهائل للمؤتمر. My presentation today will be about the recent trends in the management of type 1 diabetes.
دكتورة إيمان بعد إذن حضرتك ممكن تعملي فول سكرين.
Okay.
تمام اتفضل.
Alarming rise in diabetes worldwide. International Diabetes Federation announced a number of people diagnosed with diabetes in the year 2019 can 463 million, and this number is expected to rise to 700 million by the year 2045. Egypt is among the 10 top countries في number of people with diabetes. Egypt تحتل المركز التاسع بالنمبر of people with diabetes 8.9 مليون، والنمبر ده الحقيقه الرانك ده expected ان هو يبقى في الرانك السابع by the year of 2045 when the number of people diagnosed with diabetes will be 16.9. What's about type 1 diabetes? According to the International Diabetes Federation, the number of type 1 diabetic children and adolescents below the age of 14 is 600,000, and below the age of 19, more than 1 million child and adolescent. Type 1 diabetes is an autoimmune disease caused by T-cell mediated destruction of the pancreatic beta cell. Well, predominant pathophysiology is almost absolute insulinopenia. Therefore, lifelong insulin is the cornerstone of treatment. In fact, no disease has had an evolution of therapy and technology in the past 100 years as type 1 diabetes. Before insulin discovery, diagnosis of diabetes means death. In 1921, Banting and Best extracted insulin from dog and proved that it can control symptoms of diabetes in dogs. And the first diabetic to receive insulin was this boy known as Leonard Thompson. He was skin on bone, and he received insulin, survived till the age of 27 years, and he died unfortunately by pneumonia. And Banting and his colleague received the Nobel Prize for discovery of insulin in the year 1923. Follows that the first commercial available insulin can in 1922. This is the bottle of the first commercial insulin produced by Lilly company, and can create great advantage في سنة 1982 بالproduction of insulin by recombinant DNA technology، لأن كل الانسولين before كان prepared من البيف أو البورك يعني animal sources. Since that time, various insulin formulations were developed with various pharmacokinetic and pharmacodynamic properties, وكان في حاجة great advantage في production of insulin analogues. Insulin analogues developed by modifying an amino acid sequence في insulin molecule. Now there are 3 rapid-acting insulin analogues available in the market: insulin aspart اللي هو النوفو رابيد، والجلوزين اللي هو الابيدرا، والليسبرو اللي هو الهوميروج. والحقيقه ان compared بالريجولار انسولين بتتميز الرابيد اكتنج انسولين انالوجز ان هي لها رابيد اونست اوف اكشن، يعني بتشتغل في خلال 5 to 15 minutes. ده compared with the old regular insulin اللي هو الاكتا رابيد او الهومالين ار اللي بياخد حوالي نص ساعه علشان تو اكت. وده الحقيقه له ادفانتج رابيد اونست اوف اكشن ان هو في التشيلدرن والتودلرز اللي هم لهم unpredictable feeding habits، فان هم ياخدوا الانسولين اللي هو رابيد اكتنج انسولين انالوجز just before meals or even after meals. Another advantage of this rapid insulin analogues هو الرابيد اللي هو shorter duration of action than regular insulin، وده الحقيقه بيخلي ان في less development of hypoglycemia، وفي نفس الوقت ان هو reduced postprandial hyperglycemia. Another advantage هو development of basal long acting analog اللي هي ميل دي انسولين جلاوجين اللي هو اللانتوس، والديتيمير اللي هو الليبيمير، والجلاوجين 300 and degludec. Also these basal insulin analogues compared with NPH لها longer duration of action، يعني الجلاوجين duration of action up to 24 hours taken once daily. ديتيمير duration of action up to 24 hours بس in fact ان هو بتاخد every 12 hours ما بيكملش 24 hours. فالحقيقه this longer duration of action compared with NPH also resulting in less hypoglycemia and less day-to-day variability بالنسبه للبلاد جلوكوز absorption compared بالاولد NPH. طب اوكي which insulin regimen we will follow؟ الحقيقه اللي هو البيست انسولين ريجيمن هو that mimic او trying to mimic normal insulin production by the pancreas. ان الهيلث pancreas release insulin at 2 levels: البيزال level to suppress hepatic glucose production during the day and at night, and in that بيبقى low level, and at the time of meals في bolus insulin او rise in second level of insulin in order to match the blood glucose while rise after meals. البيزل انسولين comprise حوالي 50% من التوتال ديلي انسولين دوز اللي احنا بنديها، والبولس 50% من التوتال ديلي انسولين دوز. So the insulin regimen or the best insulin regimen is the basal bolus concept with basal insulin once or twice per day and insulin analogs before or after before meals like aspart lispro or glurozine. Okay, why this basal bolus insulin؟ لأن الحقيقة إن according to SPAD consensus guidelines 2018 in diabetes control and complication trials proved in an intensive insulin therapy اللي احنا multiple daily injection أو بالinsulin pump as well we'll discuss later ده reduce بلا شك بالincidence of development of complications in type 1 diabetes or reduce progression of the pre-existing complication. And now there is no rule for pre-mixed insulin هو زي الميكسيتارد ده خلاص not recommended for use في pediatric type 1 diabetics. And now there is recommended as I said for multiple daily injections. يعني نحتاج إلى basal insulin as one injection and at least 3 injections with the meals اللي بنسميها البولس insulin. الايم بتاعنا الحقيقه برضه according to SPAD clinical practice guidelines ان احنا هيموجلوبين A1C او تارجت هيموجلوبين A1C for all age groups ان هي تبقى less than 7. بس about هنا في النيو انسولين في عندنا السكند احنا قلنا الفيرست جنريشن بيزل انسولين كان الانسولين جلاوجين اللي هو اللانتوس والانسولين ليفيمير. سكند جنريشن بيزل انسولين في الانسولين ديجلوديك اللي هو known as تريسيبا. التريسيبا ده after long acting insulin analog ولو longer duration of action عن اللانتوس بيوصل حوالي 40 hours والتريسيبا approved في الأطفال as young as 1 year old والحقيقة إن هو له لسه hypoglycemic risk than الفيرست جنريشن بيزل انسولين انالوجز اللي هم اللانتوس والليفيمير. Another second generation basal insulin analog هو التوجيو او الانسولين جلاوجين. الانسولين جلاوجين او توجيو فيه 300 يونت بير ملي in comparison with lantus اللي هو فيه 100 يونت بير ملي ودوت FDA approved في ال children age 6 years or above. والحقيقه في 3 times التوجيو انسولين في 1 ملي as standard 100 يونت بير ملي بالنسبه لللانتوس وده بالريزلت ان فلاتر فارماكوكاينيتكس وفارماكودايناميك بروفايل and prolonged duration of action اكثر من 24 ساعه compared with اللانتوس. Another new insulin هو الفياسب. الفياسب ده approved باليو اس FDA وفي الchildren as young as 2 years وده الحقيقه ان هو fast acting insulin designed to given directly at the beginning of a meal or up to 20 minutes after eating وده الحقيقه بيقلل قوي البرانديال excursion better than ال rapid acting insulin analogs وده will be available in Egypt in the next year. Another insulin, new insulin is the pulmonary or inhaled insulin known as Freeza وده inhaled form of human insulin approved as brandial or bolus insulin for adults in the United States with similar rapid acting insulin analog لكن no much faster peak of action and shorter duration of action but still it is given in adults and approved in adults and not in children. What are methods of insulin delivery? As we all know, the old method by needles, then the development of insulin pens, في refilled أو disposable pens, وفي اللي هو ال reusable وفيها بتتملي بالكارتليج when it is used. وده الفيرست ده شكل first insulin pen and this insulin pen nowadays. في الحقيقة دلوقتي development of smart في smart pens ده advantage في الانسولين بين تكنولوجي. السمارت انسولين بين ده has memory function وكان لوج الميموري ده الديت والتايم والاماونت اوف انسولين given for several previous doses up to 1 year. والبين ده بيبقى connected عن طريق بلوتوث لسمارت فون application and allow the users to track the date والتايم والاماونت of insulin doses. Another method of insulin delivery available nowadays هو what's called the iPort. الاي بورت ده ديفايس بيجي نيدل ومعاها surrounded بsoft cannula، والانسولين بيبقى انجكتد عن طريق الانسولين سيرنج او عن طريق انسولين بن، او بتاخد شوتس في الكانولا بحيث ان النيدل ديت بتبقى above السيرفيس اوف ذا سكين، والديفايس او الكانولا بتبقى disposable after بتقعد worn for period من 3 ل 5 ايام، وده طبعا eliminate البين اللي بينتج عن انسولين انجكشن. The new progress or advantage in giving insulin delivery is the continuous subcutaneous insulin infusion أو الانسولين بامب، وده شكل الفيرست انسولين بامب. كان فيرست انسولين بامب developed في 1963 يعني أكثر من 50 سنة، وكان طبعا very heavy و carried on the back. And nowadays this is the insulin pump nowadays. This is Miss America 2014 wearing her insulin pump. What is the insulin pump? The insulin pump ده small computerized device وده mimic the way the human pancreas works, delivers small shots أو short acting insulin continuously as the basal rate. The device also used to deliver variable amount of insulin when at the time of meal بنسميها البولس shot. What are the components of insulin pump? دي التراديشنال pump. البامب دي بيبقى فيها الكنترول وفيها الباتري وفيها الريزرفوار اوف انسولين وفيها الاوبريتنج باتونز، ومع دي البامب وفي مع الديسبوزبل انفيوجن سيت عباره عن الكانيولا، والكانيولا دي بتبقى كونكتد للانسولين ريزرفوار الموجود بالبامب عن طريق ثين تيوب. دي الليتست هي انسولين بامب او السمارت بامب اللي هي اسمها الفيديترونيك ميني ميد 780 جي، ودي بيسموها دلوقتي الارتفيشال بانكرياس او كلوز لوب انسولين بامب. ودي بتبقى كونكتد معاها الكونتينوس سبكوتينيوس انسولين كونتينوس جلوكوز مونيتورنج اللي هو جارديان 3، ودي الحقيقه البامب دي بتشتغل اوتوماتيكالي وادجست البيزل انسولين every 5 minutes based على sensor glucose to maintain blood glucose level at the target. وميزتها كمان هي to suspend before low، يعني بتوقف الانسولين up to 30 minutes قبل ما يوصل البريسيت او اللو ليميت، واوتوماتيكالي بعد ما يريسيت الانسولين تاني ما blood glucose level recover. طب how does an insulin pump work؟ احنا قلنا الانسولين pump deliver basal insulin along 24 hours previous rate. يعني احنا بندي الانسولين انجكشن بدي بيبقى الريت ذا سيم اول ذا داي بالنسبه للبيزل انسولين، لكن بالنسبه للبامب انا عندي الافيلابيلتي ان انا اغير البيزل انسولين ريت وهنا حسب الايه الاكتيفيتي. هنا مثلا بالنسبه لي قبل الفجر عندنا الدوم فينومينا. الدوم فينومينا دي بيبقى فيه الفتره دي بيبقى فيه هايبر جلايسيميا وريز بلاد جلوكوز ليفل عشان الامرجنسي او عشان الجروث هرمون وعشان الانسولين ريزيستنس في الوقت ده. ففي الوقت ده انا مثلا بظبط البيزل ريت ان انا بعلي البيزل ريت. في تايم تاني during the activity مثلا بقلل البيزل ريت، فدي حاجه جريت ادفانتج ان انا الفاريبل بيزل ريت ان انا بظبطه بالنسبه للبامب. وهنا الدميل تايم بدي هنا بقى البولس انسولين ده، البولس انسولين ده بديها حسب مع الميلز حسب الميل تو كفر الكربوهيدرات الايه with the meal. اماكن وير تو انسيرت الانسولين انفيوجن سيت. هنا دي ده لايك الاماكن زي الاماكن اللي بنعمل بحقن فيها الانسولين او لايك الانسولين انجكشن. الادفانتج اوف انسولين بامب اللي هي يوزز اونلي شورت اكتنج انسولين او رابيد اكتنج انسولين انالوج، وده له less than 3% absorption variability عن الجلاوجين والان بي اتش، وبيبقى في وان انسرشن بيتغير كل 3 ايام، فده بيقلل الفاريشن في الابزوربشن ونتيجه السايت روتيشن واليمينيت موست اوف سبكوتينيوس انسولين ديبو. وديليفر بيزل انسولين ممكن ادي البيزل في تايني مايكرو دوزز، يعني ادي ممكن في التودلرز يعني دوزز قليله جدا ممكن توصل ل 0.025 يونت 24 اور بير داي. وحاجه ثانيه هي بتبقى بروجرام الانسولين ديليفري allows closest match with the physiologic insulin need. According to American Diabetes Association واليوروبيان اسوشيشن فور ستادي اوف دايابيتس قالوا ان الانسولين بامب او continuous subcutaneous insulin infusion هو الموست physiological method for insulin delivery. ليه؟ لانها تميكس الانسولين او physiologic insulin secretion by the pancreas. This is a pediatric and adolescent unit insulin pump experience. We launched in September 2019 the first pump clinic in our unit, and this is the first pump clinic in the University Hospital in Egypt. We started by 5 patients, and now in November 2020, we have 45 patients on insulin pump and 4 patients voting. الكرايتيريا عندنا for selection كان في absolute indications زي recurrent hypoglycemia, wide fluctuation في blood glucose level regardless of hemoglobin A1C, suboptimal diabetes control, microvascular complications, وجود microvascular complications أو risk factors for microvascular complications, insulin regimen that compromise lifestyle. وفي relative indications young children, especially toddlers, patients with pronounced DOM phenomena, children عندهم needle phobia, children who are prone to ketosis, and competitive athletes. This is our data, demographic data.
We are behind time.
Can impact على outcome of continuous subcutaneous insulin infusion. Our experience can في improvement في glycemic control، يعني في reduction في الانسولين A1C. البيزلاين كان 9.1 وصل 7.9 after 1 year. Reduction في frequency of severe hypoglycemia by 70%. Improvement في mean weight and height Z-score. And this table shows significant decrease في hemoglobin, statistically significant decrease في hemoglobin A1C after the use of insulin pump, and highly significant decrease في frequency of severe hypoglycemic attack per week. Another important step في management of type 1 diabetes هو self monitoring of blood glucose. Diabetes control and complication trials showed that intensive insulin therapy requiring مع self monitoring blood glucose more than 4 times per day ده delay onset and progression of microvascular complications. طبعا هنا كان يوز من سنه 71 blood glucose meters، ولكن الحقيقه ان هي في painful finger pricks ده disadvantage ليه طبعا اليوز اوف glucometers، ان هي كمان بتدي الكابيلاري بلاد جلوكوز دوت بيدي سنجل ريدنج، يعني بنسميه البوينت ان تايم، وما بيدينيش الدايركشن او ريت اوف تشينج اوف بلاد جلوكوز ليفل، وكان cannot predict الامبندنج hypo or hypoglycemia. Now this continuous glucose monitoring system develops. These devices measure glucose concentrations في الانترستيشال تيشو عن طريق سنسور، ده بيقيس الانترستيشال جلوكوز every 1 to 5 minutes، يعني بيبقى في حوالي 288 readings per day، وبيبعت الريدنجز وايرلسلي للريسيفر، والريسيفر ترانسميت الريدنجز للسمارت ديفايس with the CGM system. So this continuous glucose monitoring give complete picture للglycemic pattern including not only mean لكن بسميه time range في blood glucose level good لو من 70 ل 180 with degree of glycemic variability. ودي examples للCGM دلوقتي اشرهم في الفري ستايل لايبر. في ستايل لايبر في سنسور او باتش ده بيبقى applied على الباك اوف ذا upper arm easy to apply، وفي عندنا الترانسميتر بينقل الداتا للديفايسز لايك الفون او الكمبيوتر. Another advantage هو الديكسكوم. الديكسكوم ده هو recent CGM. الديكسكوم بيدي 14 days overview report showing all blood glucose data، وبيدي curves عن التايم ان رينج، وبيدي الافريج ديلي readings of blood glucose. في حقيقه current progress في الستيم سيل ثيرابي في التايب 1 diabetes. الحقيقه كان اول ما ابتدات الترانسبلانتيشن في التايب 1 diabetes كان البنكرياتيك ترانسبلانتيشن من سنه 66 فولد بالسنه 77 بالفيرست ايلت cell transplantation. كان في progress في this transplantation of this technology، ولكن نتيجة اللي هو الشورتج في الافيلابيلتي للدونر البنكرياس او الايلت سيلز والكومبليكيشنز اللي كانت بتحصل من الجرافت ريجكشن، الحقيقه عملت ليميتيشن لليوز اوف الايلت ترانسبلانتيشن. nowadays في بروجريس في الستيم سيل بيز ثيرابي، وده يعني هولد بروميسنج بوتنشال ثيرابيوتيك ميثود للتايب 1 دايابيتس، لكن لسه الحقيقه ستيل results of clinical trials في الستيم سيل ثيرابي في تايب 1 دايابيتس ستيل dissatisfactory، نتيجه برضه لسه ستيل في in how to implant insulin producing cells and how to convert the deprivation of insulin producing cells and how to produce من الهومن pluripotent stem cells. في هوب الحقيقه للستراتيجيز او الثيرابيز بالنسبه للإيميون ثيرابي وبالنسبه للفيوتشر جين ثيرابي، لكن كلها طبعا still not safe in humans. في حقيقه دلوقتي ادفانتج في دلوقتي development of vaccine against Coxsackie virus B، و it is well known ان Coxsackie B virus او التيبو فيروسز ان هي تبقى causal factor في type 1 diabetes. Pre-clinical testing of novel hexavalent vaccine target 6 known Coxsackie virus B serotypes showed ان الفاكسين ده له excellent safety profile بس في الانيمال او في الواين مودلز لسه، والفاكسين provide immunity against acute Coxsackie virus B infection in mice. And it blocks induced diabetes في genetically permissive mouse model. The results طبعا دي provide solid scientific base for human trials with Coxsackie virus B vaccine for potential prevention of type 1 diabetes. And lastly الحقيقة في advantage في discovery of antidote for treatment of atherogenic أو hypoglycemia، وده hypoglycemia من الميجر obstacle للإنسولين ثيرابي. ففي دلوقتي available still not in Egypt الانترنيزال جلوكاجون، ده بتاخد single powder designed to deliver glucagon and absorbed عن طريق النيزل mucosa without the need for deep inhalation، وده طبعا easy للكير جيفر اللي هو to administer ل unresponsive or comatose patients with hypoglycemia. الدوز في الchildren 4 to 6 years هو single 3 mg dose intranasal glucose glucagon, and a second dose of medication can be administered. In conclusion, the continuing emergence of innovation and novel treatment modalities has reshaped the management of diabetes and offered the potential to optimize glycemic control, improve quality of life, and reduce burden of type 1 diabetes. Like still, current challenges remain to teaching the providers how to best use these new tools, directing our medical system to allow us to best utilize these therapies, and perhaps most importantly, transferring this new technology to patients who can best apply them. Although the future is exciting, we need to first master the use of our current tools before we can successfully move forward. Hopefully, in the near future, the successful management of type 1 diabetes will become a reality for all with this disease. Thank you for listening, and control your diabetes for. Thank you. And now I have the honor to introduce my dear colleague, Professor Wafa Azza, Professor of Pediatric Hematology and Oncology and Head of Pediatric Bone Marrow Transplantation Unit. تفضلي دكتور وفاء.
دكتور وفاء, please unmute yourself. دكتور وفاء, احنا كده شايفين البرزنتيشن بتاعت حضرتك, ممكن نعمل unmute?
This is unmute. Okay, thank you, Professor Iman, for the introduction, and thank you for the organizing committee for giving me the chance to present my topic. The topic today is about hematopoietic stem cell transplantation in children in Shams University Hospital experience.
دكتور وفاء اقدر اساعد حضرتك؟
Our objectives today about definition of hematopoietic stem cell transplantation and its indication, our experience in pediatrics and where we are, what are the unmet needs and what are the future perspectives. Hematopoietic stem cell transplantation is an emerging new line of treatment. It's a cure for many diseases, sometimes the only cure and sometimes the only hope for life. It involves intravenous infusion of autologous or allogeneic stem cell to replace damaged or defective bone marrow or immune system. And this is through the ability of the hematopoietic stem cell to self-renew and differentiate into all mature blood lineage, and by expressing surface antigen CD34 and the receptors for the early acting hematopoietic growth factors. This is a hematopoietic stem cell that can differentiate into multi-potential stem cell to lymphoid progenitor cells, myeloid progenitor cells. The myeloid progenitor cells will further differentiate to give the neutrophils, basophils, lymphocytes, eosinophils, monocyte macrophages, platelets, red blood cell. So restoring all the blood elements and give natural, the lymphoid progenitor cells gives natural killer cells, T lymphocytes, P lymphocytes. So restoring the immune system. Historically, the first hematopoietic stem cell transplantation were done in 1968 to successful acute lymphoblastic leukemia. 10 years later, 100 leukemia patients were done with 50% cure rate. At that time, Thomas discovered the power of the immune system to eradicate cancer, and he won Nobel Prize in 1990 for his discovery in transplantation. What are the sources of stem cell? There are three sources: the peripheral blood stem cells, bone marrow stem cells, and cord blood stem cells. And this is how bone marrow stem cells can be collected from the posterior superior iliac spine paralateral in the theater under anesthesia from the donor. And this is how peripheral blood stem cell can be collected, apheresis machine, by the apheresis machine. And this is the bag of a stem cell. And this is the cord blood stem cells by collection from the cord and placenta. And we have two types of transplant: the autologous transplant, where the stem cell from the patient himself, and the allogeneic transplant, where the donor is another one than the patient. We have the best donor is a matched sibling donor. The best donor is matched sibling donor, followed with the matched unrelated donor. And if both is not available, we have the mismatched related donor, haploidentical, the cord blood stem cells, and the mismatched unrelated donor. What are the indications for hematopoietic stem cell transplantation in children and adolescents? According to the guidelines from the American Society of Blood and Marrow Transplantation, 2015, and more recently, the guidelines, the European guidelines for the indication of hematopoietic stem cell transplantation 2019, these are indication. We'll talk about the standard of care. S stands for standard of care, and the high evidence one, that is grade 1 or 2. Here is regarding the hematologic malignancies, AML on the top of the list, and high risk patient, relapsed patient, and more than one relapse is the standard of care for management. Hematopoietic stem cell transplantation, matched sibling donor, matched unrelated donor, and sometimes mismatched donor because it's fatal disease. In acute lymphoblastic leukemia, also high-risk patient and relapsed patient, hematopoietic stem cell transplantation is the standard of care. CML also. Myelodysplastic syndrome and juvenile myelomonocytic leukemia are very high indication for stem cell transplantation. And regarding the non-Hodgkin lymphoma and the non-Hodgkin lymphoma relapsed one needs stem cell transplantation, and for Hodgkin lymphoma, autologous transplantation is the standard of care. Here is the non-malignant indication for transplantation. On the top of the list, the primary immune deficiency, and all types of donor are indicated, the standard of care for those patients. Hurler syndrome type 1 and thalassemias and sickle cell anemia. Standard of care matched sibling donor only. For osteopetrosis, any type of donor should be available for transplantation in those patients. And bone marrow failure, acquired and inherited, are another indication for transplantation. By one explanation why AML is in need of transplantation in a group of patients. Here is in AML, more than 90% of patients can achieve remission with chemotherapy. However, more than 35% can enter into relapse. And with hematopoietic stem cell transplantation, it is the only chance of long-term survival. The outcome, overall survival, event-free survival for high-risk AML is 70% and 56% respectively. And this is a recent article in Bone Marrow Transplantation 2015 about the high-risk AML, showing that the disease-free survival more than 73% at 80 years with allogeneic transplantation. Here is a matched sibling donor. Matched sibling donor graft versus host disease, acute is low, chronic is low, transplant-related mortality is low with very good outcome. So there is again the acute and the chronic graft versus host disease with the transplant. So in AML, transplantation is very important for high-risk patient and for relapsed patient. Regarding ALL, 80% of the patient have overall survival, more than 80%, but about 20% will suffer from relapse, early relapse in the first 18 months of diagnosis needs transplantation, and T-cell phenotype needs transplantation. They both fare worse with chemotherapy alone, and they are in need of transplantation to get better overall survival. And this is a recent article about the relapsed T-cell leukemia, T-cell lymphoblastic leukemia, and this is the outcome, 47% with transplantation. It is less than 10 to 20% with only chemotherapy. In Hodgkin lymphoma, the survival rate more than 90%. However, there is 15% of patients fail to attain complete remission and they subsequently relapse. Those patients with chemotherapy and other modalities of treatment like radiotherapy got a very poor response, less than 20%. And with autologous transplant, the outcome is much better. Autologous transplant is safe, convenient, and efficient treatment. It is cornerstone of management of relapsed refractory Hodgkin lymphoma. regarding non-Hodgkin lymphoma, relapsed refractory non-Hodgkin lymphoma got dismal outcome with chemotherapy alone, and with transplantation, allogeneic transplant, the outcome is much better. And here is the an article, recent article 2019 regarding the non-Hodgkin lymphoma refractory relapsed type with outcome 1 and 3 years, 74%, 67% at 3 years, and disease-free survival 68% at 1 year, 50% at 3 years. So transplantation improved the outcome of those patients. Now, the second part is the non-malignant conditions, the benign hematology. And the aplastic anemia is a disease with dismal outcome with supportive care only. The mortality rate exceeding 80% at 2 years. And with the use of hematopoietic stem cell transplantation matched sibling donor, the outcome and survival rate exceeding 90%. And this is a curve. Matched sibling donor, age less than 20, outcome 86%. Moreover, there is an excellent outcome with haploidentical transplant in those patients because they are in need of transplantation. Not only acquired bone marrow failure is in need of hematopoietic transplantation, but also inherited marrow failure and all other marrow failure like PNH, myelodysplastic, preloukemic leukemia, all other types. Regarding inherited bone marrow failure like Fanconi, it responded very well with transplantation. And this is a very recent article from the American Society of Hematology, 2020, indicating that the outcome more than 95% for matched related donor, provided that transplantation of those patients is very early, while there is only moderate cytopenia before complication, transfusion, alloimmunization, and contamination with infections. So this is another important disease, is thalassemia. And this is a natural cause of thalassemia. This is a natural cause of thalassemia. It's a chronic, non-malignant disease. However, with the major advances in supportive care and oral chelating agents, less than 50% of patients remain alive after 35 years, while hematopoietic stem cell transplantation is a curative option in those patients with outcome exceeding 90% with matched related donor and with good risk patients. And here is class 1. Outcome more than 90%. And here is again transplantation in age less than 7 years without hepatomegaly. The outcome is very good than transplantation late with hepatomegaly. In European PMT report of very high outcome, 94%, and very low rejection rate, 10% in thalassemia patient with a substantial improvement in transplantation over the last 2 decades. Is it cost effective? Yes, it's cost effective. The cost of transplantation equal to the cost of supportive care, chelating agent transfusion in 1 year. So it's cost effective. And recently it is recommended in limited resource settings. Another disease, that is the infantile severe osteoporosis, fatal without treatment, without hematopoietic stem cell transplantation within few years. Hematopoietic stem cell transplantation is curative in those patients, especially the infantile malignant form. Here is the engrafted macrophage-derived osteoclast from the donor origin with successful transplantation, leading to remodeling of the bone structure and establishment of normal hematopoiesis and preventing or reversing the pancytopenia and the extramedullary hematopoiesis. It got a very good long-term survival. And this is recent article in Blood 2015 on large number of patients with 10 years follow-up. The survival rate is high, 62% with matched sibling donor, and dropped to 39% with alternate donor. The message is that early referral of those patients before visual impairment and before other complications of organomegaly and bone pancytopenias transfusion is correlated with much better outcome, with long-term survival, with cure rate. Now, what are the future directions for the transplantation? We have many directions. Make him match a sibling donor, the first line treatment for the old, like thalassemia, like aplastic anemia that is not transplanted. Second is to raise awareness regarding the need for cord blood banks, national cord blood banks all over the country. Third is to encourage haploidentical transplant in a country like Egypt with lacking HLA registry as another line for patient lacking matched sibling. So we need cord blood banks, national one, haploidentical transplantation with all the settings and the drugs that help establishing this line of treatment and encouraging matched related donor as soon as possible for diseases that benefit of this line of treatment. Now, about the Ain Shams University Hospital experience in pediatrics, we have done a group of patients, allogeneic and autologous transplantation, and the allogenic transplant is matched related donor. This about 40 patients, 35 of them were allogenic and 5 were autologous. The service started, the actual start 2011 till now. About 4 to 7 patients per year were done. Actually, this is very low number, and this is because we have only one cabinet with the adult transplantation unit, and the patient stayed for 6 to 8 weeks in during the transplant process. So we cannot.
We are behind time, doctor.
Okay, 1 minute. And this is the diagnosis done. This is the acquired. This is acquired aplastic anemia, 15 patients, lymphomas, 5 patients, Fanconi anemia, 7 patients, thalassemias, 5 patients, neuroblastoma, acute myeloid leukemia, 3 patients, and 1 patient of other diseases. That is osteopetrosis, adrenoleukodystrophy, severe combined immune deficiency, and so on. And this is the diagnosis. Here is the outcome. The early outcome is 75% overall survival. This is the early outcome. Late, there is drop to 68% outcome because of 5 more deaths because of disease relapse into infections, cytomegalovirus fungal infection in another 2, and disease itself in adrenoleukodystrophy in the last one. Regarding the aplastic anemia, this is the largest group. They fare very well with transplantation. The 15 patient, 11 is alive in a very good shape. That is about 70%. 70%. And in lymphoma, we have done 5 patients, 4 autologous, 1 allogeneic. The outcome is 80%, and they are the 4 in a very good shape. And this is the outcome, 80%. And regarding thalassemia, we have done 5 patients, 80% alive in a very good shape. This is the overall survival, and 1 rejected, and he's awaiting the 2nd transplant. And in conclusion, hematopoietic stem cell transplantation is a curative line for many diseases, and it is a very helpful line of treatment. Now, finally, I want to thank the pediatric bone marrow transplantation team and the clinical hematology, clinical immunology, clinical biology team, and thank you.
شكرا دكتورة وفاء على المحاضرة القيمة دي وعلى الاكسبيرينس القوية في جامعة عين شمس في البي ام تي. وان شاء الله المحاضرة الجاية معانا دكتورة أمل الفرماوي هتكلمنا على الميتوكوندريال ديزيزز 101. اتفضلي دكتورة أمل.
Thank you, Rania. Good evening, dear professors and colleagues. رانيا السكرين بتاعتي باينة ولا ايه؟
لسه يا دكتور. ممكن نرجع على الزوم ونعمل شير سكرين؟
اوكي. صح كده؟
تمام يا دكتور مظبوط. نعمل سلايد شو حضرتك.
اتفضلي دكتور أمل. تمام كده احنا شايفين كل حاجة.
Okay. My talk is about mitochondrial diseases 101, and by 101 I mean basic introductory knowledge aiming to increase awareness about this heterogeneous group of conditions that can affect any body organ at any age. The first emergence of mitochondrial diseases was in the early 60s when Luft and colleagues described a young woman with severe failure to gain weight, marked fatigue, and muscle weakness that was unrelated to thyroid dysfunction and was attributed to a severe lack of energy, and the hypothesis of the possibility of mitochondrial dysfunction emerged. This was followed by frequent reports describing the same clinical condition, and it was not late until 1988 when the first pathogenic mutation in mitochondrial DNA was identified. And now more than 300 disease-causing mutations are well known, and it is still evolving, fascinating, puzzling area of medicine actually. The mitochondria are double membrane intracellular organelles that the inner membrane is folded, forming cristae in which the mitochondrial matrix is present, and it contains the mitochondrial DNA as well as multiple functional proteins. The main function of mitochondria is that they are the powerhouse of cells, responsible for energy production in the form of ATP, and this is done through the process of oxidative phosphorylation. And in this process, 5 protein complexes making the respiratory chain or electron transport chain perform a very complicated process, ending with the formation of 38 ATP from 1 molecule of glucose. In addition to energy production, mitochondria are also involved in Krebs cycle, fatty acid oxidation, urea cycle, gluconeogenesis and ketogenesis, calcium homeostasis, biosynthesis of heme, as well as apoptosis, either as a part of aging process or in degenerative diseases. Actually, all body cells contain mitochondria except the red blood cells. But the number of mitochondria is widely variable in different tissues. Cells with high energy requirements as the neurons, skeletal muscles, cardiac muscles, the liver, the GIT. As you can see here, this is a cut section of the liver. All these tissues are rich in mitochondria and particularly vulnerable to lack of ATP. The mitochondria are unique in having their own DNA. And the difference between the mitochondrial DNA and the nuclear DNA, the nuclear DNA is linear double helical DNA that contains around 20,000 to 25,000 genes, determine all human bodies' characteristics and how human bodies are built and work, including the mitochondria itself, of course. While the mitochondrial DNA are circular. They contain 37 genes encoding for the instructions for making the proteins of the respiratory chain. It was found that immediately after fertilization of the ovum with the sperm, that the mitochondria of the sperm disintegrate and disappear, leaving only the mitochondria of the maternal side. And this is called maternal inheritance. And here we should thank strong independent mothers for being the source of energy to all mankind. As mitochondrial DNA is present in thousands of identical copies in each cell, there is a notable feature of mitochondrial inheritance, that's heteroplasmy, in which there is a wide variation in the severity of phenotypic expression of the mutation. Disease expression is determined by the percentage of mutant mitochondrial DNA. As you can see here, if there is only 20% mutation, the child will have no disease. If there is 50% mutation, there will be a mild disease. And if there is 80% mutation, there will be a severe degree of disease. The mitochondrial diseases can be inherited by all kinds of inheritance, whether maternal inheritance, nuclear genes mutations, autosomal inheritance, X-linked inheritance, a single mitochondrial DNA deletion, or multiple or depletion syndrome. Mitochondrial diseases occur when mitochondria are not able to provide the energy needed by cells to work properly due to defective oxidative phosphorylation. They are actually a collection of conditions, not a single disease. The prevalence of mitochondrial disease, they are actually not rare, but the true prevalence remain unclear. Because of the difficulties in diagnosis, as I will show you in a minute. The estimated mitochondrial disorders at birth in neonates is 1 in 4,000. The prevalence of all forms of childhood onset mitochondrial diseases has been estimated to range from 5 to 15 cases per 100,000 individuals, and at least 1 in 200 individuals harbor a mitochondrial mutation. So why we struggle to identify this disease? Because all ages can be affected, neonates to elderly, presentation changes across ages, presentation changes in the same patient at different points of time, a multi-system involvement mimics other diseases, including shock and sepsis, a wide range of symptoms from mild to severe, acute or chronic. The symptoms usually affect multiple organs. It's rare to find a one system affection, and it is classified to neurological symptoms and non-neurological symptoms. In neurological symptoms, maybe in the form of seizures, stroke, epilepsy, ataxia, migraine, dementia, and so on, optic atrophy, retinitis pigmentosa, and ptosis, very important, hearing defects, very important, myopathy and exercise intolerance, peripheral neuropathy, and the non-neurological symptoms include respiratory failure, cardiomyopathy, liver failure, Fanconi syndrome, renal tubular defects, endocrinal dysfunction in the form of diabetes, GIT dysfunction, mostly gastrointestinal dysmotility, necessitating the use of gastrostomy tubes for feeding, as well as premature ovarian failure and infertility. The list of mitochondrial diseases is big and it is still expanding. Some of patients' symptoms can fit in certain clinical conditions that we are familiar with as Lee syndrome, Pearson-Maroux syndrome, Murph, Millas, Alpers syndrome, Kern-Sire, but other patients' symptoms do not fit in a specific clinical syndrome. The diagnosis of mitochondrial diseases can be a nightmare due to the wide variety and severity of symptoms, as I told you before, and due to, unfortunately, the lack of diagnostic tools, especially in our country. When to suspect mitochondrial disease in the presence of unexplained combination of multisystemic symptoms, unexplained clinical conditions as chronic fatigue syndrome, progressive clinical course with episodes of exacerbation, family history strongly indicative of mitochondrial dysfunction, exclusion of other possible metabolic and non-metabolic disorders by appropriate testing, and especially in children, the presence of a history of stillbirth, paucity of intrauterine movement, sudden infant death syndrome, movement disorders, failure to thrive, and developmental delay. All of these are red flags to think mitochondrial disease. There are a lot of various criteria, clinical criteria, and scoring system to help the diagnosis like this one. And if you are suspecting a mitochondrial disease, you will start doing investigations. And investigations include standard blood tests as blood cell count, blood urea nitrogen, liver function tests, and ammonia. All of them are not diagnostic for mitochondrial diseases in specific. Other tests include lactate, pyruvate, CPK, fasting glucose, thyroid profile to exclude hypothyroidism that can mimic mitochondrial disease, serum and whole blood acyl carnitine, urine organic acids, coenzyme Q. All again are not very specific to mitochondrial diseases and can occur in a wide variety of other conditions. Recently, fibroblast growth factor 21 and growth differentiation factor 15, they were found to be biomarkers of mitochondrial diseases with potentially diagnostic and helpful in the management of mitochondrial disease. If all the labs of the patient are normal and you are clinically suspecting a mitochondrial disease, it is recommended to repeat testing while the patient is under stress, for example, in fasting or during illness or exacerbation of his condition, and it is recommended to do DNA testing. Muscle biopsy can be helpful in the diagnosis. As you can see here, this is the normal muscles in biopsy, and this is the red rag muscle fibers in mitochondrial diseases. And the liver involvement can be in the form of hepatomegaly, cholestasis, elevated liver enzymes, hypoglycemia, acute liver failure. Pathologically, the feature in the pathology may be in the form of steatosis that can progress to steatohepatitis and fibrosis, and abnormal shape of mitochondria by electron microscopy. Genetic testing for DNA sequencing to detect mutations in mitochondrial DNA or nuclear genes encoding for mitochondrial components is available, but unfortunately it is not available in our country. Now the treatment, mitochondrial patients should take precautions to prevent catabolism, especially when exposed to medical stressors, infections, fasting, and surgery. This will cause deterioration of their condition. Patients with mitochondrial disease also are at increased risk of anesthesia-related complications, as all agents of general anesthesia are known to directly inhibit the mitochondria. Also, these patients are advised to avoid certain medications that are toxic to the mitochondria. And on the top of the list, valproic acid. Valproic acid causes encephalopathy and hepatopathy that could be fatal due to in children or in patients with mitochondrial disease. Also, of course, you remember the aspirin with the relation with the Rey syndrome, and the aminoglycosides and its relation to hearing loss and renal toxicity. Treatment also include dietary supplementation in the form of antioxidants and vitamins, what's known as mitochondrial cocktail, coenzyme Q10, creatine, riboflavin, vitamin B2 and thiamine B1, and vitamin E, C as antioxidants, and L-carnitine. In addition to organ-specific interventions in case of liver failure, treatment of specific symptoms of liver failure or cerebral stroke, or care for the eye or GIT manifestations, and so on. Regarding liver transplantation, there is at present no consensus on the role of liver transplantation in mitochondrial hepatopathies because of the multisystemic nature of the disorders, and the review of literature showed a mixed outcome with a survival rate of less than 50%. To summarize, mitochondrial diseases are inherited chronic progressive conditions that can present at birth or later on in life with a wide range of symptoms and as well as symptom severity. They are usually undiagnosed due to difficulties in the diagnosis. If you have a high index of clinical suspicion, you should have a high index of clinical suspicion when you have a child with unexplained multi-system involvement. And diagnosis can be by clinical criteria, lab studies, especially during stress or illness, tissue biopsy, and genetic studies. There is no definitive cure so far, but there are lines of treatment that can help with the symptoms in addition to avoidance of stress and certain medications, as I showed you. Thank you so much for listening.
شكرا دكتورة أمل. حضرتك خليتي الميتوكوندريال ديزيز اللي هي حاجة كومبلكس فيري ايزي اند سهلة على ناس كتير دلوقتي. next speaker إن شاء الله دكتور وليد الجندي هيكلمنا عن الكوازاكي and updates في الكاردياك presentation. اتفضل دكتور وليد.
بسم الله الرحمن الرحيم. معلش دكتور رانيا، هو انا الشير سكرين عندي مش ظاهره
لسه ما طلعتش.
تمام.
انت عملت شير سكرين؟ يلا انشر.
انا معايا دكتور. حاضر.
هي لسه ما جاتليش.
تمام دكتور، ممكن نقفل الزوم ونفتح البرزنتيشن من بره خالص؟
اوكي.
مساء الخير يا دكتور وليد.
مساء الخير دكتور منى، ازاي حضرتك؟ اخبار حضرتك؟ منوره. انا شايف حضرتك طبعا منوره حضرتك.
هو دكتور وليد اكيد قدم لنا حاجه اكثر من رائعه، والدكتور وليد one of the pillars of pediatric cardiology معانا في القسم، فهنسمع حاجه جميله ان شاء الله. اتفضل دكتور.
ربنا يخلي حضرتك دكتور، ربنا يخلي حضرتك يا فندم.
دكتور وليد فتحنا البرزنتيشن؟
انا فتحت البرزنتيشن حضرتك.
ممكن نمينمايز ونرجع على الزوم تاني؟
تمام، انا اون زوم حضرتك. شير سكرين. ظهرت لي شير سكرين.
نختار البرزنتيشن منها يا دكتور.
تمام، ام دان كده يا فندم. ظاهره كده يا فندم؟
مظبوط يا دكتور. ممكن نعمل سلايد
اوكي.
اتفضل.
بسم الله الرحمن الرحيم. في البداية أنا بحب أشكر أستاذتي الأستاذ دكتورة منى الجنزوري the head of Pediatric Department Ain Shams University. أشكر ال Organizing Committee ورسوم دكتورة رانيا إبراهيم for giving me the opportunity to share in the annual Congress of Pediatric Department Ain Shams University. My talk about an update of Kawasaki disease. الحقيقة أنا had just like a brief على الكawasaki لأنه معروف للجميع ولكن هعمل فوكس أكتر على ال cardiovascular manifestation. I'd like to give an overview upon the history of Kawasaki, epidemiology and etiology, presentation and diagnosis, treatment and the cardiovascular manifestation, and how we are going to follow up patients with Kawasaki disease. The old identity of Kawasaki disease given by John Burns of San Diego اللي هو اسمه mucocutaneous lymph node syndrome is a self-limited vasculitis of unknown etiology that predominantly affects children younger than 5 years, mostly younger than 5 years. It's now the most common cause of acquired heart disease in children in the United States and Japan. Original case observed by Kawasaki in January 1961. He was a 4-year-old boy with unknown diagnosis. The coronary artery thrombosis first recognized in 1965 on autopsy of a child previously diagnosed as mucocutaneous syndrome. The first Japanese reports of 50 cases in 1967. First English language report from Dr. Kawasaki in 1974, simultaneously recognized in Hawaii Island. What is Kawasaki disease? Kawasaki is known as idiopathic multisystem disease characterized by vasculitis of a small and medium-sized blood vessel, including the coronary arteries. The median age of affected children around 2 years age, 80% of cases in children less than 4, 5% of cases in children more than 10, male to female ratio 1.5 to 1.7. It recurs in only 30% of cases with positive family history in 1% of all cases. Overall, U.S. and hospital mortality accounts for 0.17%. The annual incidence 4 to 15 per 100,000 children under age of 5 years. Overrepresented in Asian Americans, African Americans come next, more prevalent with seasonal variation in winter and spring. The biggest question about Kawasaki: what is the etiology of Kawasaki disease? It may be related to infectious versus non-infectious agents. The infectious agent most likely age-restricted, seasonal variation, well-defined epidemics, acute self-limited illness similar to non-infectious. The non-causative agent identified may be bacterial, retroviral, super-antigenic bacterial toxins, immunologic response triggered by one of several microbial agents. The first case identified a novel human coronavirus and respiratory secretions from a 6 months old with typical Kawasaki, ودي اتنشرت الحقيقة سنة 2005 ودي كانت the first presentation relation between Kawasaki and the hidden coronavirus infection. Subsequently isolated from 8 over 11 patients of Kawasaki patients and 1 over 22 matched controls. This suggests the association between the viral infection and Kawasaki. The diagnostic criteria, as we all know, it comes first fever for at least 5 days, والفيفر حقيقة ممكن تعدي 38 ونص, and at least 4 of following 5 features: changes in the extremities, including edema, erythema, and desquamation, polymorph exantheme, usually truncal and centripetal, non-purulent conjunctival injection, erythema and fissuring of lips and oral cavity, with cervical, usually unilateral cervical lymphadenopathy, and illness not explained by other known disease process. بنيجي تاني الديفينيشن معظمنا بتبقى نجد فيه بعض الحيرة اللي هو atypical or incomplete Kawasaki. It present عادة with at least 4 of 5 diagnostic criteria, compatible laboratory findings. Coronary aneurysm may still has the chance to be developed في incomplete form of Kawasaki. There is no other explanation for the illness. It's more common in children less than 1 year of age. The American Heart Association guidelines that 2004 offer new evaluation and treatment algorithm for the incomplete form. الحقيقه ما فيش سنجل confirmed lab investigation ان انا اكونفيرم الدايجنوزس اوف كاواساكي ديزيز، ومن هنا بيجي الرول ان انا افهم الديفرنشال دايجنوزس وان انا اكسكلود الديفرنشال دايجنوزس كوزز كلها، وفي الاخر بيجي لي الرول بتاع كاواساكي. نيجي للانفكشنز، عندنا الميسلز والجروب A بيتا هيموليتيك ستريبتوكوكال انفكشن closely resemble الكاواساكي disease, bacterial severe staph infection with toxin release, الفيرال adenovirus والانتيروفيروس بشتاين بار والرزولا، وريسنتلي طبعا الكوفيد 19. Spirochetal infections, parasitic infestations like toxoplasmosis, rickettsia infections like Rocky Mountain spotted fever and typhus. A role of immunologic or allergic reactions play a strong role. The systemic onset of juvenile rheumatoid arthritis, a typical presentation of acute rheumatic fever, hypersensitivity reaction, and Stevens-Johnson syndrome, with mercury toxin presentation. الفيزز اوف ديزيز احنا بنمشي في 3 phases: acute, subacute وconvalescent. الاكيوت بياخد من 1 to 2 weeks from the onset of the disease, include الفيبرايل والirritable والtoxic appearance illness, oral changes including a rash والedema والerythema of a feet. Subacute phase follows الacute stage ب 2 to 8 weeks from the onset, including discoloration with gradual improvement even without treatment. The convalescent stage month to years later afterwards. This is the presentation للacute stage في الدورسة of hands and feet including erythema وedema في hands and feet. دي الإديمة اللي موجودة ملي في الدورسة of both feet اللي بتبقى مميزة جدا في الacute stage. ده الفينجر تيب اند تو تيب بيلينج اللي بتبتدي تظهر في السب اكيوت فيز اوف كاواساكي، وعاده بتدينا جايد ان دي فعلا العين بتاعنا كان كاواساكي ديزيز. دوت السنتروبيتال بوليمورفوس نون فيزيكولار ماكيلوبابيلوريشز اللي بتبقى بريزنت على الترانك والسنتروبيتال اريا وماي اكستند 70 to 80% من الكيسز على منطقه الجروين. دوت الصورة اللي على اليمين بشوف النون بيرلينت conjunctivitis، وعادة بلاقي في حاجة اسمها perilimbic sparing، ان انا بشوف اريا من الوايتنس بتفصل من الكونجنكتيفال انجكشن وما بين الايرس، والدوت الفيشرنج والريد ستروبري تونج والكراكس اللي بتبقى موجودة في اللبس. هنا عادة بلاقي إن بيبقى فيه cervical lymphadenopathy، وبلاقيها significant، بلاقي إن فيه cervical lymph nodes أكتر من 1.5 centimeter in diameter. As regards Kawasaki disease symptoms and signs includes multiple organ affection and respiratory like rhinorrhea, cough, pulmonary infiltrates, gastrointestinal diarrhea, vomiting and abdominal pain, hydrops of the gallbladder ودي بتبقى manifested في الabdominal ultrasound. Neurologic manifestations include irritability, aseptic meningitis, and facial palsy, hearing loss in some cases, musculoskeletal, including myositis, arthralgia, or even going to arthritis. الحقيقة دي abdominal ultrasound showing الgallbladder زي ما حضراتكم شايفين ان انا بشايف huge distension للgallbladder with thin lining of the mucosa، ان الgallbladder membrane مش thickened ومفيش calculi inside الgallbladder، دي اللي احنا بنسميها high drops of gallbladder. اللابس بتاعت الكاواساكي may help in diagnosis ولكنها مش confirmatory زي ما حضراتكم عارفين. Early lab includes leukocytosis with shifting to left, mild anemia, thrombocytopenia versus thrombocytosis, elevated acute phase reactants like ESR and CRP, hypoalbuminemia, elevated transaminases of the liver, and sterile pyuria. Late manifestation includes thrombocytosis and elevated CRP. As regards the cardiovascular manifestation of acute Kawasaki, it includes electrocardiogram or ECG changes, any sort of arrhythmia, abnormal Q waves, prolonged PR and QT interval and corrected QT intervals in some cases, low voltage ECG, ST and T wave changes, while X-ray may show cardiomechanic changes. As regards the manifestation, it may be none. ممكن العيان ما يبقاش عنده أي cardiac manifestation أو يجيله cardiac manifestation suggestive of myocarditis، ودي بتبقى في حوالي 50% من العيانين including tachycardia that disproportionate to fever and anemia with soft flowing murmur over the apex of the heart and galloping rhythm. في symptoms suggestive of pericarditis ودي بتبقى present في حوالي 25% of cases. Also symptoms بتبقى very rare. ممكن اسمع distant heart sounds, pericardial friction rub or even tamponading. وعادة احنا ليه بنعمل فوكس على الكارديولوجي في الاكيوت setting؟ عشان first of all I have to document the baseline coronary artery status ودي بتبقى عادة not an emergency. لكن لو myocarditis develop طبعا of course it's an emergency ودي في نفس الوقت كمان can help diagnose atypical disease. يعني لو أنا عندي عيان presented with a typical form of Kawasaki ولقيت أي حاجة من ال cardiac manifestation it help diagnose. The echocardiographic criteria I may found myocarditis with dysfunctioning of the systolic functions of the LV, may found pericarditis or even with pericardial effusion, valvular insufficiency, والأهم هو حالات coronary arterial changes. The coronary arterial changes حوالي 15 ل 25% of untreated patients develop coronary artery changes. 3 to 7% if treated in the first 10 days of fever with intravenous immunoglobulin kit still has a chance to develop coronary artery and changes, and most commonly affect the proximal parts of the coronaries more than distal. In order of sequence, it affects mainly the left main, left anterior descending, and lastly the right coronary artery. The coronary artery changes vary in severity from the echogenicity due to the thickening and the edema of the endothelial lining of the coronary vessels, or even asymptomatic coronary artery ectasia to giant aneurysm. It may lead to myocardial infarction and sudden death or ischemic heart disease. The coronary aneurysm may vary in size, may be small, less than 5 millimeter in diameter, or medium-sized, range from 5 to 8 millimeter, or even giant, more than 8 millimeter in diameter, and has got the highest risk for the sequelae. Its shape may be fusiform or circular in shape. Coronary aneurysm, patients with coronary aneurysm most likely to develop aneurysm. في كرايتيريا الحقيقه كان في واحد امريكي قال اسمه هارتز طلع الكرايتيريا ولقينا ان البيشنتس اللي هم younger than 6 months or older than 8 years in males, in fevers that persist for greater than 14 days, or persistently elevated ESR, in patients with hypoalbuminemia, in patients with thrombosis, patients who manifest symptoms or signs of cardiac involvement هم الحقيقة اللي بيبقى عندهم تشانس أكبر ولازم ناخد بالنا أكتر إن هم may develop the coronary aneurysm. دي الحقيقة echocardiographic view and short axis view showing this is the aorta, this is the left main. احنا coronary شايفين حضراتكم ان هو dilated beyond the usual diameter for age and sex, وهنا بيدي البرانش of the left anterior descending احنا شايفين ان hugely dilated وفي الاخر في saccular aneurysm في موجود في البيشنت دوت. ده عيان تاني showing الأورطة وادي البرانش الليفت كرونري فيه hugely fusiform aneurysmal changes موجودة في الليفت مين كرونري. الحقيقة دي حالة interesting كانت منشورة في مجلة أمريكية ل young female lady حوالي 33 سنة. هي died after labor. لقوا كان مدية history إن هي عندها وهي 16 سنة developed كawasaki عند سن 33 died after labor, ودي كانت الاوتوبسي بتاعها. ده عندنا فيه huge aneurysmal change موجود في right coronary artery as regards huge aneurysmal change موجود في left coronary artery. الظريف في الموضوع ان البيبي بتاعها اللي اتولد at the age of 5 years developed Kawasaki for unknown reason, وده اللي بيدي strong predilection of family history. الانجيوجرافي ستيل له البرايورتي العاليه قوي عشان اشخص بيه الكوروناري تشينجز اللي بتبقى موجوده، وبقدر اشوف بيه البروكسيمال والديستال تشينجز عشان اقدر اشوف فيه هل في اي مشاكل تقدر تحدث في الكوروناريز ولا لا، واقدر احدد الفولو اب في العيانين with giant aneurysm. البروجنوزس للانيوريزم حوالي 50% بتريجريس to normal by echo, 25% become getting smaller in size, 25 do not regress. Only 7 to 20% develop stenosis or myocardial infarction attributed to their aneurysm. The coronary aneurysm approximately حوالي 50% زي ما قلنا بتريسول خالص getting smaller in size or get fusiform morphology. ده بيبقى more common في الفيميل gender وفي الage less than 1 year. لكن عادة giant aneurysm more than 8 mil they got the worst prognosis. 0.3 to 2% mortality rate due to cardiac disease. 10% منهم بيبقى early myocarditis أو الانيوريزم بتاعتهم may thrombose causing myocardial infarction and death. Myocardial infarction is principal cause of death in Kawasaki disease, constituting around 32% of the mortality, most often in the first year of life, majority while at rest or even sleeping, about 1/3 of the asymptomatic presentation. In treatment of acute Kawasaki, يأتي على رأس القائمة intravenous immunoglobulin بدوز of 2 grams per kg as one-time dose. Beneficial effect first reported by the Japanese. الميكانيزم of action بتاعتها الحقيقة is still unclear. Significant reduction في coronary artery aneurysm in patient treated with intravenous immunoglobulin plus aspirin versus the aspirin alone, with efficacy beyond the 10-day of the start of the treatment is still unclear. The intravenous immunoglobulins giving 70 to 90% of Devarvis and show symptom resolution within 2 to 3 days of treatment. الحقيقة بعض الأحيان بنحتاج retreat those with failure of response to first dose or recurrent symptoms لحوالي 2/3 response to a second course من الانترافينوس immunoglobulins. بندي معاهم الاسبرين، بنديه بالانتي انفلاماتوري دوز بتاعته من 80 إلى 100 مل per kg per day until afebrile status في حوالي 48 ساعة ونديكريس في الأكيوت phase reactants. ممكن نحتاج high doses in acute phases نتيجة المال absorption of aspirin. الدوز في الأكيوت phase does not seem to affect the subsequent instance of coronary artery aneurysm. اوكي انا فاضل لي خلاص قربت اخلص. هجري بس السلايدز بتاعت التريتمنت. عايز بس ادي هنت على البيشنتس فولو اب كاتيجوريز. احنا بنقسم البيشنتس ل 5 كاتيجوريز based on the coronary artery finding. هل عندي coronary changes ولا لا؟ في transient coronary artery ectasia according to the size of the coronary aneurysm. المانجمنت بتمشي في 4 ستيج: الفارماكولوجيك ثيرابي، الفيزيكال اكتيفيتي، الفولو اب اند دايجنوستيك تيستنج، والانفيسيف تيستنج انكلودينج الكاس انجيوجرام. همشي بسرعه في الدي ستيجز ولكن لازم ادي هنت على الحقيقه البيدياتريك مالتي سيستم انفلاماتوري syndrome which is first recognized in March, reported April 2020 in UK, with severe illness including varied presentation of Kawasaki disease or incomplete form of Kawasaki or COVID-19 toxic shock syndrome with or without cardiac involvement or shock organ dysfunction. COVID-19 may be positive or negative. The persistent fever with inflammation including high white cell count, low lymphocytic count, and high CRP, evidence of single or multiple multi-organ dysfunction including shock, cardiac, GIT, etc. Exclusion of other causes of microbial cause. SARS-CoV-2 testing may be positive or negative. Lastly, I'd like to say COVID-19 associated hyperinflammatory syndrome may be presented with refractory shock due to the vasodilation with toxic shock syndrome with normal cardiac function, or even septic shock with impaired cardiac function may be presented with Kawasaki disease or combination of all of the above. And so finally, thank you for your listening.
Thank you so much, Dr. Walid.
شكرا لحضرتك يا فندم.
Very illustrative talk. Slides are very well done. انا بس عاوزه ازود حاجه، ان احنا دلوقتي في وقت الكوفيد الناس بتقول ان الاطفال ما بيجيلهاش كوفيد ديزيز او بيجي unnoticed. لا، بيجي لها كوفيد وبيجي لها by the picture of Kawasaki disease. عشان كده الكلينيكال فيتشرز اللي الدكتور وليد قال عليهم المفروض يبقوا spread knowledge all over every doctor you know. لان اما يجي المنظر ده لما خدش IVIG in the first week of the disease better ان هو ياخدها في the first day or the second day، بيحصل له ممكن يحصل له coronary aneurysm. وزي ما هو قال ان الcoronary aneurysm الانسيدنس بتقل جدا بدل 25% to 5%. فممكن نعيدها تاني عشان ايه الطفل ده يعيش بعد كده with normal heart. and thank you. نقدم الدكتورة داليا الغنيمي نيو انسايت. اتفضلي يا رانيا قدميها.
اخيرا وليس اخيرا ان شاء الله الدكتوره داليا ان شاء الله اتكلمنا على الكومن فاريبل اميون ديفيشنسي الابديتس، ويعني هو دايما مواضيع المناعه بتبقى صعبه بس داليا حقيقه بتسهلها وتقربها ويهم ان احنا نستمتع بالمحاضره ان شاء الله. اتفضلي.
دي كانت المفروض تيجي في الاول عشان نكون لسه فايقين يا رانيا والله.
لا ما احنا هنفوق عشان الماتش ان شاء الله.
الا
عشان خاطري عشان خاطري حضرتك.
اتفضلي يا دكتوره داليا. اتفضلي.
شكرا. هل كده ظهرت ولا؟
تمام واضحه يا دكتور. اتفضلي.
طيب. بسم الله الرحمن الرحيم. I would like first to thank the organizing committee of this highly scientific conference, all my professors, colleagues, and every personnel sharing this great event. My talk is about a new insight into management of common variable immune deficiency, one of the commonest primary immune deficiency. The objectives of my talk is to address the role and protocol of therapy of immunoglobulin replacement in common variable immune deficiency, determine the role of immunosuppressive drugs in management of associated non-infectious disorder, and recognize the recommended approach for management of asymptomatic patients. I have none to disclose. So starting with common variable immune deficiency, it is the most common symptomatic primary immune deficiency, and about 25% of all CVID patients present in childhood or adolescence, and there is an earlier peak of diagnosis at approximately 8 years of age. So as a pediatric immunologist, we are facing this disorder, although it might present in adulthood. Patients with CVID present with a broad range of clinical manifestation, including recurrent bacterial infections, autoimmunity, interstitial lung disease, enteropathy, lymphoproliferation, malignancy, and allergic disease. So we can see it is a very heterogeneous clinical disorder. About 8 to 10% of patients with laboratory confirmed CVID have little or no significant medical history of infections. And this does not exclude the diagnosis of CVID and does not exclude the risk of catching severe infection at any time during the course of their life. This patient may have a low serum immunoglobulin G discovered incidentally or more commonly in association with autoimmunity or other complication of CVID. So the diagnostic criteria for CVID developed because of this clinical and immunological heterogeneous presentation. In 2013, there is a group of scientists led by Mertonga developed CVID criteria, and the international consensus developed by the American Academy of Allergy, Asthma, and Immunology, and the World Allergy Organization, and the American College of Allergy and Asthma and Immunology. They developed a consensus criteria to define CVID in 2016. And lastly, the ACID registry developed CVID criteria in 2019. They have variable criteria that differ in details between them, but all the three criteria agree on the following: that diagnosis established to diagnose symptom might develop before the age of 4 years, but to establish the diagnosis of CVID, it should be at the age of 4 years. Low level of immunoglobulin G is a must to be related to the age normal range. Other causes of primary and secondary hypogammaglobulinemia must be excluded, and absence of profound T-cell disorders, whether in the number or in the function. So coming to the management of CVID, we have the immunoglobulin replacement therapy, and we all know that immunoglobulin replacement therapy is a cornerstone in many of the PID disorder, primary immune deficiency disorder, treatment of infectious disorder, mainly relying on antimicrobial therapy, treatment of non-infectious disorder, and management of asymptomatic patients. Asymptomatic means no history of infection, but with or without autoimmune disorder. And what about vaccination in this group of patients? And lastly, hematopoietic stem cell transplantation, which is a very debatable issue in this disorder. Immunoglobulin replacement therapy reduce the number of infection and decrease the antibiotic use and hospitalization. And this is a very well-known scientific and practical point. And we have to know that immunoglobulin replacement therapy is not a mere passive transfer of immunoglobulin exclusively to prevent recurrent infection, but also have an active role in regulating the autoimmune and inflammatory response through modulating B cell or other cell functions. So what about monitoring of these patients? Steady state levels are usually achieved after 3 to 6 months of therapy, and therefore trough level of immunoglobulin G are measured 6 months after the first dose and then every 6 months thereafter. This is very important because premature measuring of the trough level of immunoglobulin G will give false data about the stabilization of the dose given to the patient, whether it is less and should be increased or it is high and should be decreased. So we have to respect the serum level reached and the steady state level of the immunoglobulin G to be reached after 6 months and then checked after. So what about the target, our target? The dose of immunoglobulins, mainly intravenous immunoglobulin, ranging from 300 to 600 milligram per kg to be given every 3 to 4 weeks. The subcutaneous immunoglobulin is at lesser dose, 100 to 200 milligram per kg every week or every other week. My target is to keep the level of immunoglobulin G near to be at least near the middle of the normal range for age. So, for example, if the patient norm is from 600 to 1,200, so it should be kept near 900. It is no more to be kept at 500. This is a very rough estimation for the trough level, but it does not necessitate to be the correct one in every patient. And together with keeping the level of immunoglobulin G in the blood acceptable to the normal range for age of the patient should experience a significant decrease in major infection. So post-target should be achieved on initiating intravenous immunoglobulin therapy or subcutaneous immunoglobulins. So what about indication for higher dosing, so as to keep the patient at 600 milligram per kg or maybe higher, like at 800 milligram per kg or maybe at 1 gram? Continued major infection in spite of regular administration of immunoglobulin replacement therapy, chronic lung disease, whether a complication of infection bronchiectasis or interstitial lung disease or granulomatous lymphocytic interstitial lung disease, enteropathy, and this is also because of excessive loss of the immunoglobulins. And if the patient has autoimmune disorders that necessitated use of immunosuppressive therapy. We are not just increasing the dose of immunoglobulins to jump from 300 to 600. No, we increase the dose gradually by 0.15 gram per kg per month. Or another way is to shorten the duration, and instead of giving it every 4 weeks to be given every 3 weeks, which can increase the dose by 33%. So what about treatment of infectious disorder? We know that antimicrobial therapy represents a cornerstone in the management of PID. As much as we can to get cultures, sputum or nasal swab and to get the results, but at many times we are resorting to empirical treatment, respecting the susceptibility of this patient to certain types of organisms, mainly encapsulated organisms. So we are starting with amoxicillin clavulanate or third generation cephalosporin and fluoroquinolone to defend against Streptococcus pneumoniae, Haemophilus influenzae, and Moraxella catarrhalis. In case of suspecting mycoplasma, macrolide antibiotics is the choice. And because of acute exacerbation of cyanopulmonary infections by Staphylococcus aureus, Pseudomonas aeruginosa, and anaerobes, carbapenem or beta-lactamase inhibitors penicillin, third-generation cephalosporin should be used. In addition to antimicrobial, there must be a very good hygiene, nasal hygiene, saline irrigation, and chest physiotherapy in bronchiectasis. And in addition to inhaled drugs in bronchiectasis, like inhaled glucocorticoids and aminoglycosides. Surgical treatment of chronic sinusitis is usually not recommended because it is invariably recurrent. So every effort should be done to control with medical treatment. And in severe bronchiectasis, if resistant to treatment by immunoglobulin replacement therapy and antimicrobial, surgical removal of the most damaged part of the lung can be done. High-resolution CT and lung function tests are a must, should be done at diagnosis to identify the degree of affection of the lungs and any associated pathologies, including granulomas formation, interstitial disease. But because of high-dose radiation, should not be performed at regular interval unless there is acute event happened. In place of high-resolution CT during follow-up of the patient, magnetic resonance imaging of the chest to provide good alternative, together with regular pulmonary function testing for this patient at least annually. So prophylactic antimicrobial does not represent a main line of management of patient CVID, of patient with CVID, except if the patients have declining lung function, severe bronchiectasis, chronic sinus disease, and frequent acute infection episode despite proper immunoglobulin replacement therapy. And there is no general consensus regarding the protocol of using whether intermittent, continuous, or rotating antibiotic between macrolides or amoxicillin. So it is left for the treating physicians. And suitable drugs include amoxicillin, trimethoprim sulfa, and macrolides. The benefits of macrolides is that it provides additional anti-inflammatory effects in these patients with a very strong predilection for inflammation. And for gastrointestinal infection, they are at risk for Giardia, Campylobacter, Salmonella, and Cryptosporia. Generally, Giardia, whether acute or chronic, responding to metronidazole. And for Cryptosporia, nitazoxanide is a very good choice. Azithromycin is the primary antibiotic for treatment of Campylobacter and Salmonella gastroenteritis. So coming to the treatment of non-infectious disorder, they're starting with autoimmune cytopenia, which is a very common presentation for these patients. Corticosteroid in a standard dose are usually sufficient, but usually higher doses of intravenous or immunoglobulins, like 1-2 grams per kg per month, can be used to supplement baseline therapy with oral steroids and to taper the oral steroids and achieve remission. In case of refractory or recurrent cases of immune thrombocytopenic purpura and or autoimmune hemolytic anemia, rituximab provide a very good choice, and it is not does not provide a increased risk for infection in this patient if the patient is committed to regular monthly administration of intravenous immunoglobulins. Splenectomy is the last resort treatment of severe refractory cases of autoimmune cytopenias. So granulomatous disorder, corticosteroid, granulomatous disorder can affect the lung, the liver, the lymph nodes. Corticosteroid is the initial treatment, but in some cases of severe or refractory cases, cyclophosphamide, hydroxychloroquine, rituximab, azathioprine, and methotrexate have been used. Some patients need combination of these cytotoxic and immunomodulatory drugs, like using rituximab and azathioprine in patients with granulomatous and lymphocytic interstitial lung disease is a very good results. Intravenous immunoglobulin replacement therapy may improve the pulmonary function test in patients with granulomatous and lymphocytic interstitial lung disease and improve the radiographic findings. Infliximab has been used for skin granulomas, but risk should be weighed over the benefits because there is increased risk for biogenic or mycobacterial infections that will not be prevented to a great extent by the immunoglobulin replacement therapy. Coming to the immune-mediated enteropathy, this patient are at risk for IBD and inflammatory bowel disease-like disease, and it is the same treatment like in patients with primary inflammatory bowel disease, like using the 5-aminosalicylic acid and absorbed oral steroids. Systemic low-dose prednisone can be used, but every effort should be done to limit the dosation of high dose prednisone, because this would increase the risk of opportunistic infections. Immunomodulators like azathioprine or 6-mercaptopurine can be used safely. Infliximab as well, same like in skin granulomas, but every effort should be done to closely monitor the patient to avoid overwhelming infection. These patients are at risk for malabsorption, and so supplement, including protein, vitamins, and mineral, should be supplied as required. And definitely this requires a multidisciplinary team between the gastroenterologist, and the same for autoimmune cytopenias between the hematologist, and in the granulocyte lymphocytic interstitial disease between the pulmonologist and the pediatric immunologist. It is not a one-man show management. So what about in asymptomatic patients without history of infection with or without autoimmune disorder? There is a consensus that if the immunoglobulin G is mildly decreased and the specific antibody response to vaccine show mild impairment, so these patients, the immunoglobulin replacement therapy may be postponed, but these patients should be followed at reasonable intervals every 6 to 12 months, as a progressive decline in immunoglobulin G and the specific antibody response could occur. So at this time, immunoglobulin replacement therapy should be initiated. So what about if this patient have very low levels of serum immunoglobulin G, who have little or no vaccine response, and although they are asymptomatic, there is consensus that it is not wise at all to postpone the immunoglobulin replacement therapy, and it should be given because of risk of severe infection at any time these patients can be exposed to. Inactivated vaccine given with variable efficiency, and inactivated influenza vaccine is recommended. Live vaccine like oral polio, live attenuated influenza vaccine, yellow fever, or live oral typhoid vaccine should be not given. And specifically, oral polio vaccine should not be given to family contact, as transmission may occur and immunoglobulin replacement therapy may not be protective.
We are behind time.
Okay, حاضر يا رانيا حاضر. Hematopoietic stem cell transplantation have not been considered to have an important role in treatment of CVID, and mainly done in patients with hematological malignancy or severe refractory associated complications. In the 25 patients who underwent hematopoietic stem cell transplantation, 48% was the mortality, and they got refractory GVHD, graft versus host disease, and therefore benefit versus the risk should be weighted before advising the patient and encouraging the patient to undergo hematopoietic stem cell therapy. So at the end, we have challenges in management of CVID. In general, we have problem concerning primary immune deficiency, which is lack of national registry for primary immune deficiency disease in Egypt, and this limits the prevalence, does not give the real prevalence and the real burden of this disease in our country. The poor awareness of the heterogeneous presentation of CVID patients result in delayed diagnosis, and this increased morbidity and mortality. The lifelong need for immunoglobulin replacement therapy has its economic burden, which might at a time result in shortage of supply or giving lower doses than it should be. Lack of wide-based longitudinal studies to explore the clinical and immunological feature of CVID response to treatment and outcome, and lack of genetic diagnosis, especially for CVID patients with marked immune dysregulation and infection. So our future direction, inshallah, is to work on construction of national registry for PID in Egypt. This will give answers about the real prevalence of the disease, the need and burden of PID in Egypt, increased awareness of primary care physicians, family medicine doctors about the heterogeneous presentation of these patients. This would help early referral of these patients for further evaluation by pediatric immunologists, encourage wide-based researches, therefore evidence-based recommendations can be developed to optimize early diagnosis and management of CVID, implementation of next generation sequencing for genetic diagnosis of CVID patients that or CVID-like patients whenever needed, especially for those with immune dysregulation, and this can offer specific treatment by diagnosis of the genetic disorder underlying, offering them stem cell transplantation. In the end, I would like to acknowledge the Pediatric Allergy and Immunology Unit, which is founded by our professor Yahya Al-Gamal and all my professors and colleagues who work hard to achieve the best care for the patients. I would like to acknowledge the Pediatric Department, host all of us, and we work and we do our best to achieve the best care for the patients. And thank you very much for your attention.
Thank you Dalia very much. وختامه مسك فعلا يا داليا. It is a very good easy lecture. بس أنا عاوزة أسأل سؤال، هل لغاية دلوقتي الBCG بيتاخد في السن بدري كده ولا تأجل شوية لسنة شهرين 3؟
لا للأسف حضرتك هو لسه بيتاخد، وإحنا في العيانين اللي بيبقى عندهم family history بنكتب لهم ورقة ريبورت إنه not to be next يعني child to not to give the BCG أو الأورال بوليو لغاية ما to make sure that this patient is free of primary immune deficiency.
الأورال بوليو بيتاخد في أول يوم.
بس حضرتك هي أو الطفل المصاب ما بيتلحقش، احنا بقى بنتكلم في الطفل اللي جاي. يعني لسه حضرتك كان في حاله ودكتوره حنان ابراهيم كانت عارفاها، كانت حاله primary immune deficiency commonly يعني presenting because of the lymphopenia، هي ما لحقتش to be investigated بس present as severe combined immune deficiency. العيانه دي كانت جايه disseminated BCG and she died.
And I had a patient like this.
احنا عندنا حضرتك الريسك اوف disseminated كذا عيان chronic granulomatous disease و severe combined immune deficiency وحصلوا disseminated BCG. يعني till now يعني almost ما فيش survival من disseminated BCG.
Thank you Dalia, thank you so much. رانيا عندنا وقت for questions ولا ايه؟
احنا فاضل معانا 5 دقايق.
طب في حد عنده اي سؤال؟ أنا شايفة في الشات في سؤال واحد بس مش عارفة سؤال ولا شات. لا مفيش سؤال. رانيا عندك أنت شايفة أسئلة؟
لا هو أنا بس كان ليا سؤال للدكتورة إيمان منير. هي دكتورة إيمان حضرتك معانا صح؟
أنا مش عارفة، أنا كان ليا أسئلة للدكتور هشام بس شكله مش
كان سؤال لدكتورة إيمان منير، هل يا ترى أنواع الإنسولين اللي حضرتك عرضتيها النهارده كلها available في مصر ولا دي حاجات ما نزلتش؟ وحضرتك حطيتي كرايتيريا للسلكشن للبامب في حين ما حضرتك برضه حطيت ستيتمنت ان الجايد لاينز بتقول انه هي دي البيست كير فور دايابيتس دلوقتي. فهل لو حد عنده الاوبشن ان هو فاينانشالي كويس ويقدر يستعمل البامب يستعملها من الاول ولا لازم يبقى في السلكشن كرايتيريا دي؟
والحقيقه بالنسبه لاول سؤال بالنسبه لانواع الانسولين هي كلها افيلبل ان ايجيبت ما عدا الانسولين هو فياسب اللي هو اخر واحد هو الفاست اكتنج انسولين انالوج، ده لسه ما نزلش في مصر وان هو اكسبكتد ان هو ينزل السنه الجايه ان شاء الله. لكن باقي الانواع من الرابيد اكتنج انسولين انالوج زي الانسولين سواء الفيرست او السكند جنريشن افيلبل ان ايجيبت، فما فيش فيها اي مشكله. بالنسبه طبعا الانسولين بامب اللي هي البيست ميثود فور انسولين ديليفري تو ميميك فيسيولوجيك انسولين سكريشن باي ذا بانكرياس. الحقيقه بالنسبه للكرايتيريا دي اللي حاطينها بالنسبه للاسباد جايد لاينز، لكن نو هارم يعني فعلا هو حتى من ايرلي او يونج ايج او تودلرز هم يعني الانسولين بامب ان هم يركبوها ما فيش فيها مشكله، ولكن لازم طبعا البيشنت برضه يبقى ويلنج ان هو يعمل فريكوينت بلاد جلوكوز مونيتورنج، ان يبقى في جود اديوكيشن بالنسبه للانسولين بامب وفولو رولز هاو تو مينتين ذيس انسولين بامب. مين وايز ما فيش اي طبعا زي اذر اديوكيشن، وطبعا في ده سelection كرايتيريا برضه كان عندنا في
دكتور طارق انا ليا سؤال لك ما تقومش اصل انا شايفاه بيقوم
لكن دي كانت عندنا الانسولين بامب اللي هي عندنا بالنسبه في اليونت يعني.
دكتور طارق، انا كنت عاوزه اسال على الرابid لاج رايز اللي انت قلت عليه، هل ده دلوقتي بيتطبق عندنا في الرعايه وكده ولا لسه؟
هو leg rising test, it is a very easy procedure which I recommend it too much ان نستخدمه.
يبقى احنا بقى نتفق مع حنان تبتدي نعلم الولاد
مش محتاج يعني. it is a very simple, very simple method.
طب كنت عاوزه اسالك ليه ايج ليميت؟ يعني مثلا لغايه سن كام؟
لا خالص.
يعني النيونات ينفع لاي
ايج، ينفع بشرط after تعملي ستروك فوليوم قبل وبعد.
ميرسي قوي دكتور طارق. طب احنا نقول بقى الكلوزنج سيشن ولا ايه، ولا في حد عاوز يسال حاجه ثانيه؟ انتوا طبعا كلكم عايزين تشوفوا الماتش هنخلص. I'd like to thank my dear colleagues and professors for the excellent talks. I'm so impressed الصراحه، يعني كل واحد احسن من الثاني، يعني مش قادره اقول يعني انا استفدت قد ايه النهارده وانا قاعده. انا شفت كله وانا بشوف كل الليكتشرز very illustrative up to the point. وفي الاخر بقول stay safe، خدوا بالكم من الكورونا. it is يعني increasing rapidly like a monster. يعني ما فيش، انا اعرف ناس كتير قوي عندها كورونا، بس اعتقد ان السيفيريتي اقل كتير من المره اللي فاتت، بس في حالات برضو very complicated وفي الانتنسيف كير. وفي الاخر enjoy the match between الاهلي والزمالك and good night. رانيا عاوزه اشكرك يا رانيا.
ربنا يخليك يا دكتوره منى.
والله يعني ثانك يو سو ماتش، يعني مترتب هايل. ثانك يو سو ماتش.
ربنا يخلي حضرتك، وشكرا لايريس ايفانس والكليه والبانل بتاع المؤتمر.
طبعا مجهود خارق بصراحه، بس انا شاكره
ان شاء الله السنه الجايه نبقى فيس تو فيس، نرجع تاني
باذن
فيس تو
الله.
فيس.
يا رب يا رب يكون الفاكسين اتعمل.
ان شاء الله.
اوكي يا جماعه، ثانك يو سو ماتش، وتصبحوا على خير.